Good morning, everyone.
Morning.
We've been waiting a few minutes to see if Nellis decides if it's going to work today or not. So at the moment, it's a maybe. So that's a real definite maybe also. So we all have hard copies in front of us as we work through the day. Hopefully, those in the audience and viewing from afar will be able to keep up with us on Nellis. We will do everything possible to make sure all the information is available, but technology is a wonderful thing until it is no longer technology. So it thinks we're in the old Capitol building today, so all I want to know is where was the well? Okay. I'd like to know where that was located. So with that, Madam Secretary, if you would go ahead and call the roll, please. Thank you.
Senator Parks? Here. Senator Kiekeffer? Here. Senator Smith? Mr. Bobzien? Here. Mr. Hambrick? Here. Mr. Hickey? Here. Mr. Horn? Mrs. Kirkpatrick? Mr. Kerner? Here. Mr. Sprinkle? Here. Chair Carlton?
Here, if you would mark the other members present as they arrive. I know there's a number of meetings and bill presentations this morning. So with that, welcome everyone to the subcommittee meeting. Standard announcements, cell phones, laptops, please keep those in mind. We will work through these budgets. Today we've got a long agenda. So with that, let's go ahead and get started. I believe Ms. Gruner, are you up first today? We'll be starting with budget 3140.
Good morning, Chairperson Carlson and committee members. I am Jane Gruner, Administrator for Aging and Disability Services Division in the Department of Health and Human Services. With me at the table today is, to my far left, Tina Gerber-Wynn, Deputy Administrator for Programs, and Janet Murphy, Deputy Administrator over Operations. We will be presenting the budgets for both Aging and Disability Services and Developmental Services. I will be starting off this morning with an overview of our funding sources, a brief update on regarding sequestration, and our vision for integration, followed by our presentation of the budgets. Starting on page 2, you will find the funding sources for Aging and Disability Services, followed on page 3 by the funding sources for Developmental Services. On page 4, you'll find a pie chart on sequestration and the effects of this on aging and disability services programs. The reduction overall is a 5% reduction, and that it figures to about $2.1 million. The types of programs that are affected are senior employment, funding programs related to elder abuse, legal assistance, preventative health programs, the ombudsman programs, nutritional incentive programs, assisted technology, and a small piece for Part C and early intervention. We are currently in discussion with the director's office to see if there's any additional tobacco funds that we'd be able to use to make up for some of the losses that we have. Our next topic will be our integration. And our vision for integration is to build a continuum of care across the lifespan, a system evaluated and judged by the outcomes of the individuals using the system, where the words, "you are eligible for services," ring out in place of the tearful pleas of parents that say, "where's the right door?" Our current challenges are rapid growth, funding limitations, lack of provider availability, poor data collection methods, and inaccessible services, and they cross all the program lines. The challenges, although affecting different populations, seem to have a common thread related to all of our services. And the thread is the need for a quality, supportive service system focused on individual need, regardless of age or disability. Aging and Disability Division envisions weaving stability, flexibility, and integrity through the fabric of each program. In the end, creating a continuum of care that is proactive in developing the types of supports consumers want and delivering the services in a person-centered fashion, always remembering that the individual is the expert about what they want and how they want to receive their services. Our initial goals for integration are to plan improvements in building a system that values and retains consistent, effective providers across the services, that integrates a management system guided by accurate data, that provides accessible services when the service is requested, and that continuously assesses and evaluates our performance based on our stated outcomes. And we'll be talking more about the 5-year plan that we plan to develop with our stakeholders. The first phase of our integration process begins with building a solid infrastructure and standardizing our policies and procedures for the overarching areas that support our continuum of care. That would be our support services, which would include our fiscal operations, our human resources, and our information technology system. Next would be our quality assurance component, which would create a statewide process for creating, monitoring, and evaluating our service outcomes. Followed by our program processes, and this would entail aligning our policies and processes between our programs so that they align and match. Standardizing our intake and eligibility processes and developing specific transition criteria. While we are integrating our internal systems, we will also be implementing the second phase of our integration process, which is focusing on the development of a 5-year strategic plan created with our stakeholders to guide the division in setting performance outcomes and addressing current and unmet needs for the Nevada citizens. This phase will also address critical areas of concern, such as standardizing our data and evaluation protocols to enhance our ability to use data to drive our service system and the needs that we find. On pages 6 through 9, you will find a proposed 4-year timeline for achieving the integration that we anticipate would result in consumers obtaining services when the service is needed, be proactive in individualized service delivery system, having a streamlined system that avoids service disruption and improves consumers' choice and satisfaction, that creates a standardized intake and eligibility process where the eligibility determinations would cross division programs. An example would be a child diagnosed with an autism spectrum disorder in early intervention would be qualified for the autism treatment assistance program in aging and disabilities, and possibly for developmental services without additional testing and applications. On pages 10 through 13, you'll find an organizational chart that supports the proposed integration of early intervention moving from the health division, developmental services moving from mental health and developmental services into aging and disabilities services division. And now I'll entertain questions.
Excuse me, not much of a voice today. Committee, questions? Well, if you have a question, let's go ahead and ask the questions, or if you prefer to, when we get into the individual budgets, whatever you'd like. It's the committee's choice, whichever you'd like. Mr. Sprinkle? Yes, Mr. Sprinkle, go ahead.
Thank you, Madam Chair. Good morning. I'm just curious, when we're looking at this 4-year timeline, what procedures does the agency already have in place so that you're sure that you can be meeting these standards and getting sure that you do get to where you want to be 5 years from now?
Well, because we're just coming together, we have been doing work groups and have a plan for implementing these systems. I would say that the timeline outlines when these deliverables would be completed. We have as you know, in this budget, we do have a one-time or one-shot for an integrated computers or information systems, which would be part of this. But basically, we have already started the process of aligning our policies and protocols.
Thank you, Madam Chair. So, so then I would assume that the communication's happening right now amongst all the different departments to make sure everybody's on board with this. I also noticed that the 5th year, you don't have any objectives at that point. Is that just kind of in case you don't meet all the standards within the first 4 years? Is that why you've got that in there?
We actually did it according to legislative sessions. We figured by the end of the 4th year, we would be spending much of our time evaluating where we needed to go next. This timeline would be adjusted after the completion of the 5-year strategic plan to embed the outcomes created by the stakeholders.
Other questions from the committee at the moment? I think I'd like to go back and ask something along the lines of a historical question. I guess listening to a lot of the discussions over many, many years, I remember when the conversation was these entities are too big. They're too hard to manage. They're too hard for constituents and those in need to work through the system. And that's when we started breaking them apart and making them easier to manage. And now it seems as though I thought the systems were working fairly well. I mean, there's always glitches, but fairly well. And now it seems as though we've totally switched it back and we're going back to a larger system again, and we're reincorporating everything. And I would hope that we wouldn't create something that can't be navigated by the constituent that is so large. So I guess I'm just wondering, it just seems as though we got to the point where people understood where everybody was and where all the services were, and now we're rearranging the chairs again. And I just really want to know what the real problem is that we're trying to solve. And I appreciate a 5-year plan. We've said many, many times in this committee and other committees, we really appreciate someone saying, yes, we have a plan for the future, this is where we want to be. I appreciate that. I just want to make sure that it's actually solving the problem that exists today before we go forward. So if you could expand upon that, that would be helpful.
Jane Gruner for the record. I would say that by bringing early intervention, developmental services, and aging together, you have some synergies that are not available in other program areas. We have similar provider types. We have similar information systems needs, mainly case management. And I would say that by bringing, and we have similar advocacy groups and commissions that would be guiding this process. So I would think that throughout this system, it makes more sense to have programs together that share common themes throughout their business. which is quality assurance pieces, because that is overarching for all of our service system. Creating really quality provider types and the ability to monitor those entities. Our fiscal piece has to be experts at doing contracts. So I think what we've done is put together similar service types that can be strengthened by weaving together the types of systems that each entity alone also needs, but together will be strengthened because we get the best of all of each of the systems as we've grown up. Developmental services is an example of they have spent many years developing their quality assurance piece to support providers in delivering that service. And the direct service is done by community providers, but they've worked together to build a really strong system. So they have the scope of work and they have the certification process to make sure that what we're asking they can do and that they are doing. So I think in this process what we would find is that each part of this team, the early intervention, the developmental services, and the aging programs would be strengthened by this move.
And if I understand you correctly, the early intervention piece that you were talking about is the proposal for community providers, not what actually is being practiced today. So you're incorporating that particular proposal in the future, but that has not yet been decided, so.
Correct.
Okay. I think I would like to look back at the history, and I'll do some research on my own. I mean, if you don't learn from history, then you don't learn at all, and I just don't want to see us make the same mistakes we've made in the past. It just seems as though every 10 to 12 years, someone has to come up with a new way of doing things, and I just want to make sure that this is the right way, and that we won't be here 6 years from now trying to break it apart because people can't navigate through it. So this is a very serious issue, and I think we're going to have to really deliberate on this and truly look at the history of these agencies and move forward from there. So history should not repeat itself if it did not work the first time. So with that, are there any other questions from the committee on the overall presentation? And we'll just go ahead and go through, I guess, the individual budgets now.
Okay.
And some of this will be overlapping amongst each other, so we'll try to cover them, as efficiently as possible.
Good morning. For the record, my name is Tina Gerber-Wynn, and I'm the Deputy Administrator for Aging and Disability Services over the Aging and Disability Programs. I'm starting on page 14, which is budget account 3140, and that is our tobacco settlement funds. For this budget account, we operate home and community-based services for seniors. We fund through this money's services such as transportation, caregiver support, information and assistance. We will see some effect on this account from our reduction of federal funds under Title 3B. We did speak to the administration on community living, and we're advised that this fiscal year, our decrease would be about $389,000 for our Title 3B. So our tobacco settlement funds, we will have to address some of that loss with this funding budget. We do provide respite services through this funding, and I know there is some discussion and several bills out to support family caregivers who take care of Alzheimer's, younger people affected by Alzheimer's. We will be able to address that if that law does pass and we are to serve people with the respite monies who are younger with Alzheimer's disease. So this budget serves about 9,500 clients a year. On page 15, I did want to mention that in all of our budgets, we're going to be talking about Enhancement 804 decision units. And these are the units that we use to show our specific agency cost allocation. We do have a cost allocation plan for our support services, including fiscal, IT, and personnel. And so the budget figures noted on each individual budget will be noting our administrative cost allocation for support services. So E804 is noting that for this particular budget unit. And we did show our 5-year funding for these services, and we did have a little dip in fiscal year 11 and 12, and we're building back in this biennium those funds. And I'd be happy to answer any questions.
Any questions on this item? Didn't see any major issues. So, no? I think we're, yes. Chair Smith?
Respite care. Thank you, Madam Chair. I just wanted to ask a quick question about the respite care. Our voices between
I
the two of
know.
us don't
We don't
make
have
one
much
good
left.
voice. You mentioned if that SB 86 passes about the availability of respite care, how will the funding for that work? Because I know we changed the effective date to make it as soon as possible, but will there be some access to funds based on where you are now?
For the record, Tina Gerber-Wynn. I did speak to the Alzheimer's Association of Northern Nevada to find the number of people who potentially could be served, and it's very small. So we are not predicting an impact. We do have respite providers right now, and we will just have to change our service descriptions, mainly the age of individuals served, so that people affected by AB 36 could, or SB, AB 86 could be included.
Thank you very much. So that means that if it were to pass, and because it's upon passage and approval, that even in this current budget, you could find some funding?
That's correct.
Okay, thank you very much. That's good news.
Already. Thank you. Okay, with that, no other questions? We can move on to the next budget,
Okay.
3151.
For the record, Tina Gerber-Wynn, and I do have a cold too, so I'll try not to lose my voice or cough, but I might have to turn my head. On page
Par for the course
16,
in this room for the last 2 months, so don't forget.
page 16 is our budget account 3151. This is our administrative budget, the budget in which we administer our federal funds as well. The first decision unit I would like to talk about is E225. And this is a request for a program officer for statewide management of our volunteers who provide services for several programs. We've specifically noted the programs in which we use volunteers. Last biennium, we were lucky to have funding to start a volunteer program for our ombudsman program. We advocate for seniors and people with disabilities in nursing homes and group homes. Additionally, we have a senior health insurance program where we assist people with signing up for Medicare and assessing which plan might work for them, and a senior Medicare patrol program, which assists people to identify fraud in their Medicare and Medicaid billing. And for this program, we would like to have a program officer to help us recruit all the volunteers that we are using in these programs. Right now, we have about 102 assisting SMP and SHIP, and 22 for our ombudsman program. These individuals help for access to care, some cost avoidance in regards to people being in the right insurance, and improving care in nursing homes and group homes. We do have a funding mix for this position across these federal funds, and I would say that all these monies have been affected by sequestering, so our request for general funds is modest, but we feel that would be the best amount for us to continue, as well as using federal funds for this position.
And I'm sorry, how many volunteers did you say?
For the SHIP and SMP programs, they share 102 volunteers, and then for the ombudsman program, it's 22. And we're constantly recruiting. It's very intense training, understanding Medicare and Medicaid, so they are very dedicated volunteers. As well as our ombudsman, they have to go through a 14 or 15 level course of understanding how nursing homes operate and the things they should be advocating for.
And I apologize if I'm missing something. So this is a brand-new position. You don't actually have a designated person in this position right now? Or
It
you
is a
do-
brand-new position. We do have some contract staff, but we would really like to make this a fortifying position because there is a lot of coverage for the volunteers. We have to make sure they have workers' comp, they understand the reporting requirements, so there's quite a bit of management to the volunteers.
And how would the reduction in some of the federal funds with some of these activities affect these programs and this new position in general?
I'm sorry, could you ask me one more time so I make sure I answer correctly?
There's some reduction in federal funds on a couple of the programs, and if those get reduced and you have volunteers working in those programs, but you have this program manager to how will the reductions affect the programs in general, and then the new position as far as managing all the volunteers?
The contracted programs, well, the programs have contracted individuals in them at this point. We have discussed potentially having to reduce some of their hours of work. So it does impact some of the contracted volunteers we have managing on sites. We have several sites, so they might have to reduce hours. Potentially, we might need to lose a part-time person in regards to that. And as far as this position, we have cost allocated across several funding streams and are paying attention, obviously, to any other reductions that might come through.
Okay, so there is a cost allocation, so it will be divided amongst the different programs, so it won't be, if one program is impacted greatly, it won't be as big an impact to the overall program of volunteers then?
That's correct.
Okay, just to make sure we understood that. Any other questions, committee, on this particular new position? Mr. Sprinkle?
Thank you, Madam Chair. Just really quickly, in regard to recruiting these volunteers, have there been any issues? Is it easy to find volunteers to fit these roles?
For the record, Tina Gerber-Wynn, it is a skill set that is not common, so it is difficult. People have to be comfortable with Medicare and Medicaid and being in facilities, nursing homes. So there is a special group of people that we have to recruit. So we have had a lot of people express interest and they go through training and they really have to be committed. So it's not an easy task to recruit them. We're ongoing with recruitment.
And retaining them? Is that, do you have good success with retaining? It's a lot of volunteers, so I'm wondering where you get them and if you keep them.
Tina Gerber-Wynn, for the record. I guess I can say my name 15 times today, but or 20. It is difficult to recruit, but once people are locked, they're very committed. I was fortunate to be at a banquet or a reception luncheon for them yesterday. Once a year, we try to hold honorary events for them. They're very committed. They spend hours to help people resolve issues, not just related to Medicare, but just in general helping people figure out how to get through our bureaucracy. And so once they're in, they're in. We have people that stayed 12, 15 years. A lot of state employees, have several in the room that were there yesterday that retired and wanted to come back and work for our agencies through these programs. So it's, once they're in, they seem to be very, very committed, 10, 12 years. So retention is not the issue, but I do know they like their acknowledgments, and I would say federally, and I don't know if I should make this statement, but for CMS, they are having some difficulty with those recognition events, but that's one of the things that we do to keep them coming. So we're going to have to create a magic solution to be able to continue to hold those for all the volunteers that we have. I can see their faces now. They really enjoy the recognition, and they should get that acknowledgement.
Yes, volunteers definitely should. So, okay, any other questions from the committee? Being none, thank you very much. We'll go ahead and move on to the next one. the next item in this budget?
So page 17, E228 and E229 increases the network connectivity for our Carson City and Reno offices. Basically, we're looking for more bandwidth so that we can actually run our data systems and answer the phones. E490 it funds a state long-term care ombudsman program authorized by the Administration on Aging through the Older Americans Act. And in this particular decision unit, last biennium, we were able to use civil monetary penalties to fund some of our positions in this program. And as I mentioned, it's advocacy for seniors and people with disabilities in nursing homes and group homes. We were advised by the Center for Medicare and Medicaid Services that civil monetary penalties, the use of those funds was revised under the Health Care Reform Act, and we had a long list of items they could be spent on, and staffing and funding agency ombudsman programs was not one. So we worked with them through the biennium and advised that we would be asking for another funding source other than civil monetary penalties this budget round. So they did give us 2 years to address this issue. So this budget item fulfills our obligation to ask for $245,000 each year, the biennium of general fund, for this program.
And you're going to have to help me with the civil monetary penalty funds. It's something I'm not as familiar with. This is a little bit on the new side for me. And understanding exactly what you cannot use it for any longer so that we can keep that in the back of our minds as we work through these budgets. So if you could explain that to me in
Absolutely.
layman's terms, please.
Sure. No acronyms? Okay, I can do that. Actually,
A few, but not a lot. I've got a couple of them, but that's the best I can do right
well,
now.
I'll take a word from Jane. I'll explain what we can do with them actually in a positive light. The civil monetary penalties are fines that nursing homes receive based on reviews from the Bureau of Healthcare Quality and Compliance through the Health Division. If there are deficiencies, they are sometimes fined, and the monies go into this pot. And it is basically designed to help them improve their performance, meaning nursing homes. So there's a list of items that the Centers for Medicare and Medicaid Services have asked us to consider for pilot projects. So they'll approve short-term 2 or 3 year projects to improve quality in nursing homes, such as culture change to help people understand how important it is for residents to have choice in care and to participate in scheduling, to develop family councils so families can advocate for their family members in nursing homes, to improve just protections of certain rights within the facility, passing out information so people know how to choose the right facility and advocate once someone's in the facility. I could keep going on and on. The one part that they also could be used for is if a facility lost an administrator, they were in jeopardy in some way, we could use the funds to appoint a temporary administrator, things such as that.
And the impacts on the long-term care ombudsman, you're not allowed to use the funds for that any longer?
We are not.
So we need a bridge to get across until we figure out what we're going to do with that position in the future. Now, can that be position, I'm just trying to figure out how you plan on dealing with that position in the future and what happens if we don't fund this. Where does it end up going?
If we do not fund this, we will lose half of our staff, about 5 ombudsmen. Right now, we have 10 statewide. And they handle the more difficult issues regarding complaints. Our volunteers help with regular visits, but our paid staff are essential in addressing complaints. Some of the impact would be, one of the biggest examples is that we've had facilities that are in bankruptcy, smaller, well, mid to small size group homes. We've moved people to other facilities, so we would not have staff to do things like that without this funding.
All right, and can volunteers be used to augment these services?
Volunteers can be used to augment the more simple problems, and I don't mean to minimize their skill set. It's just that there's some technical confidentialities with records and those kind of things.
Yeah, we know there are limits between paid staff and volunteer staff, so just want to make sure we understood that. Yes, Senator Kickover.
Thank you, Madam Chair. Tina, if we put general funds into this, is there a maintenance of effort requirement going forward?
Not to my knowledge, but I would have to check. I don't believe so.
Okay, thank you.
Okay. Any other questions from committee members? Seeing none? We can
Kathy
move
did
on.
tell me I had 3 hours, so I guess I'll use all 3. So, okay, page 18, E710 and E711. Did I skip E710? Oh, E710 is throughout all our throughout all our budgets. We are talking about requesting computer hardware and software based on the I'll just say EATS, Enterprise Information Technology Services Schedule through the state. So you'll see that throughout all our budgets. And then E711 is requesting a replacement system in Reno. We cost allocated the replacement of a phone system across several budgets. And we're requesting the new phone system because it's very old. We can't find replacement parts, and we can't add any staff in that office unless we expect them not to have a phone, because there is no other way to add a phone. So that's what E711 does. And then E804 is there to talk about our cost allocation. We talked about that earlier. And E805 is a request to reclassify a budget analyst 2 position to an administrative services officer 1 to adequately support our fiscal unit. That's noted on page 12 of the org charts that we gave you. It's position 025, and it's part of our agency restructuring. Looking.
Are there any questions from the committee? Mr. Sprinkle?
Thank you, Madam Chair. In regard to E805 and E806, once this consolidation occurs, how are these jobs, these positions, going to remain the same? Are they going to be different? What kind of effect is the consolidation going to have on them?
For the record, Janet Murphy. For the most part, their duties are going to remain the same. In the organizational chart, like on the IT organizational chart, the application units, most of those positions are currently at mental health and developmental services. They'll be supporting, and performing the same type of duties. And same with the HR and the fiscal. That being said, we are going to be looking to centralize some of our processes. And with that, there'll be some changes with the personnel, but it's all within their classifications, duties. So we're working with staff now and preparing plans on that.
Any other questions? Seeing none, well, I think we can go ahead and move on.
Okay, so I thank you for the introduction to E806. That's on page 19, and this request salary for the administrator and 2 deputy administrator positions, an increase to be with similar level with other divisions within our department. The next decision unit is E807, and this requests a reclassification of a management analyst 2 to a management analyst 3 within our grants development unit. And I would say for all the reclassifications that we're proposing, we would work with state personnel, obviously, to make sure we had suggested the right position level and classification. E900 and 901 transfers positions between our administrative account and our home and community-based program account, which is 3266. This is really a cleanup. We tried to put all our positions into a one administrative account, and we missed several positions that we wanted to have in this administrative account. E510 through 531 and E910 through 931 transfer some positions and realigns positions within our integration, and also purchases some equipment for those particular supportive service functions.
On the new positions, if you could describe the duties of the administrator and the two deputy administrators, how the duties would change after this consolidation, and the discussion points about a 9.8% increase when, I mean, I'm sure you're well aware of talking about pay increases this session, so we won't go down that road. Everybody knows what the feelings are on that. So, but I'd like to understand the duties and then the discussion around that.
Jane Gruner for the record. This would bring these positions to equity with other positions such as the Department of Child and Family Services. The administrator would be over, it would go from 250 employees to 850 employees. And approximately about 12,000 consumers would be under this division after it's integrated. The duties would be in alignment with the duties in similar divisions across the state. So they would, the deputy over operations would be looking at infrastructure issues such as information technology and bringing on board a new, hopefully, a new information systems for developmental services, bringing together a fiscal staff to have a central point to make sure that all aspects of our fiscal areas are covered. Our human service or our human resources would be under the operations, so they would be in charge of assuring that we have enough staff to provide the services. The program person would be over bringing together all these programs so that they have similar policies and that the procedures match and that they can cross over program lines. So it would become one entity versus three different programs. And the administrator would be charged with having a vision that takes into account the struggles and the joys of creating a really fabulous division that serves people in the way they need to be served.
And the 9.8% just puts you basically in the ballpark of other administrators at that responsibility level.
Correct.
But currently, these would only be with the consolidation.
That's correct.
So they're not doing it now. Okay. All right. Any other questions from the committee? Sure, Mr. Sprinkle, go ahead.
Thank you, Madam Chair. I just want to kind of go back to the overview of this whole consolidation again and what you were just referring to. Are there going to be any duplication of services once all these different departments are integrated together? What can the individual expect when the consolidation actually happens? I mean, I'm talking kind of that whole continuum of care sort of thing. Is there going to be a duplication? Is it going to be as smooth as what you're really trying to describe here?
Jane Gruner for the record. I would assume that the consumer initially will not see a difference, other than it will be easier to obtain the services in the way that they would like to see them. Our policies will be aligned so that whatever is happening in early intervention would also be the policy that was happening in developmental services. So you would, I'm assuming and would be guiding our staff that we're going to make it easier for people to access services. Instead of being told no, if you're not going to be told no, you're going to be told, if you do not qualify, where do you go to get that service? And making those connections happen. But I do not think that there would be overlap of any particular service. Go ahead.
For the record, Tina Gerber-Wynn, I would add this comment. Many of our programs are dictated or constrained, created based on federal rules that allow for reimbursement, and we aren't able to duplicate because we can't then receive funding for the program. So we have to keep our programs in line with those federal requirements. From the endpoint of the consumer, they don't need to know all those particular federal headaches. They do need to be able to answer some questions so we can get them into care. But on the back end, we'll negotiate all the payment pieces and make sure that we're providing the right type of services for that funding source, as well as making sure that they have the person has the right care. So it's a behind-the-scenes thing. That's what we're describing. You ask about technicalities within our agency. The federal rules dictate payment in so many respects for our programs, so we have to be on top of those to then take opportunities to provide other services. So when we're building and our programs, they seem obscure and a little bit uneven, but that's really related to the funding more than our desire to have a smooth playing field for people. So we're trying to work that out on the back end and make sure we bill correctly, don't duplicate, can validate what we're spending so that we can continue to receive federal funds for the majority of the programs that we run. I hope that helps a little bit.
Mr. Sprinkle, go ahead. And then
Thank you, Madam Chair. No, it absolutely does. And I think kind of where I'm going at with all this is when I'm hearing you say that the consumer may not notice too much of a change. This is a lot of internal efficiencies that you're trying to work on. I'm just trying to figure out what the problem is that, or if there's a problem that is causing this major consolidation, what you're trying to accomplish with that.
Jane Gerner for the record. I think it's less about that there's a problem than it is about creating a system that is efficient and meets the needs of a broad spectrum of consumers.
I don't know if you want a story, but I'm good at stories. I would just say that people who come to us have no other choice. And I would say that not because we're not nice people, because there's a lot of nice people in this room, but they have to come to us because they have no other way to provide for themselves. They don't understand how to seek treatment for their child. They don't understand how to become eligible for Medicaid, so they come to us. So the issue is that we want to make it easier for people in that time when they're needy. They need help and advice and guidance. And so our point would be to make them come through, figure out what they need so they don't have to go through all of that many times. And that's our ideal. I know it won't be perfect, but that's what we're trying to do. So it really isn't a problem. We're trying to make it easier for people who are coming to us when they're in crisis or very, very upset to explain all the crazy things that we make them go through to then come into care. So that is what we're trying to achieve. And if it solves a problem for people, that's what we're here for. Quite honestly, that's why the consolidation makes sense to all of us from a service perspective, because we know how hard it is for people to have to tell their story and to ask for help. It's very, very humbling. I can tell you other stories, but I'm not supposed to tear up today.
Well, and what I'm getting out of this is that we have multiple silos of services. And people have to access each individual silo. I guess what I don't understand is why would we have to create a big, large silo with everybody in the same one rather than just breaking them down and allowing each of them to talk to each other? I don't think there's anything that prohibits you from breaking down those silos now without actually doing a much bigger silo. It just seems to me as though the problem is the small silos, and here we are creating a big, large silo. So I just don't, and it's not that I don't trust your judgment. I mean, you're doing this because you believe it's right, and you're very passionate about your folks, and I can see that in your faces. You really care about what you're trying to do here. I just want to make sure that we're not creating something so big that people can't, and like I said earlier, can't maneuver through it. And that's my ultimate concern, and want to make sure that, you know, when we combine all these silos, that those individual walls still aren't there, but all encapsulated in one big one. And we haven't created another set of problems. And I'm sure you've discussed this a number of times. So we haven't, so we're still trying to wrap our heads around it and understand, because we don't want to be the ones getting the phone calls and emails 6 months from now, parents upset because they can't get their children through the system. And the system worked before, but now it doesn't. What did you do to this? And so we really, and so it's not that we're trying to be critical, we're just trying to understand and really wrap our brains around this so we can explain it to folks when we get home. I think we have a couple more under 3151, the 900s and 510, I believe. Have a couple
Actually,
more.
this is Tina Gerberwin for the record. I did read those. I can read them again.
Oh, no, I had a question on 510, and if I missed it, I apologize. I want to understand the data warehouse, what we're trying to accomplish with the data warehouse and the IT staff that you have now. We hear IT every day, every budget. So we want to make sure that the system you have now that you're using and converting to this warehouse, are you going to have the staff to actually do it? What benefits and efficiencies are going to come from this warehouse? And the utilization, what you anticipate the utilization to be. So I apologize if we skipped over it earlier and I didn't get to the questions. I'm just still trying to wrap my brain around a lot of the other issues in this budget.
For the record, Janet Murphy. What we're proposing in the E510 is it's actually dual purposes. We're proposing a couple servers and a storage device with some software. It'll be dual purposed in that it'll provide an environment for our application team to develop without having to impact production until they properly have developed and tested. So that's the first purpose. The second purpose is it will start us on with a central repository for report, which is your data warehouse. And there what we're doing is leveraging currently the developmental services staff, which is coming over in the transition, is working on a data warehousing system for developmental services and the substance abuse program, the SAPTA program, where they're working on this data warehouse infrastructure for dual diagnosis and tri-diagnosis. Jane will help me out on this part. But so they're building that architecture and that infrastructure right now. And when the transition happens, we'll leverage that architecture and bring it over with the developmental services. And their system is called DS Now. So they'll be able to report out of that. And then the goal is that with aging and disability services, our case management system is referred to as SAMS. We will start working transitioning our reporting structure into the data warehouse. So now we can cross-report, and an application of that would be autism. We have autism and early intervention in our autism treatment program, or ATAP, and aging and disability services, as well in developmental services. Now we'll be able to have data in a central repository that we can query across to pull information.
Do we have IT staff that can do this?
Yes, the team that's coming over from developmental services is currently involved in building that architecture now. And they will come over with that knowledge and that architecture and be able then, because they're building modules, they'll have the understanding then to build the modules that are needed for aging and disability services.
Okay. Just wanted to make sure
Yeah, I understand.
we
Yes.
understand this.
Yes.
We've heard too much about IT for the last
Okay.
couple of months, so we just want to make sure we really wrap our heads around that one.
Sure.
Any other questions, committee, on that item or any others that we may not have? Oh, and Senator Smith?
Thank you, Madam Chairman. Just thinking about your comments about the people who you serve, and I know that you tend to have a lot of advocates in that world at both ends of the spectrum, as far as the younger and the older and then disabled. How have you involved the stakeholders and the people who you do serve? I'm sure there are some perhaps federal requirements in some cases to involve your stakeholders, but I know we always have a lot of advocates on these issues. So one of the things I was thinking about, and I see Mr. Molenkamp in the audience, and we've talked a lot about performance budgeting, performance-based budgeting, and one of the things I hope to see more of in the future is more public meetings about the budget ahead of the legislative session, which that legislation allows. So how did you involve stakeholders in this really major integration and consolidation of services?
For the record, Tina Gerber-Wynn. We have many commissions based on certain programs. Again, some of them are federal requirements. Our department has an advisory committee for people with disabilities. We fortunately were able to create a plan about 10 years ago to have a group monitoring our ability to provide services for people with disabilities. And that group has continued, and we've advised them as we've gone forward. Our previous administrator, I know she's here, I saw her walk in, we have been talking about this for a year with people so they can give us their opinions and concerns and statements. We have a commission on aging that meets quarterly. It's a group of people who are interested in aging issues, and they advise our department. They too have been advised of the change. We have a commission, or I'm probably giving the wrong name, for people with developmental disabilities. We call it the DD Council. People in that group have been advised. We have several working bodies that we work with to give them information, and I think Jane can tell you additionally what committees there are with the developmental service side.
Jane Grinner for the record. I wanted to also add that we did have an employment summit in 2010 that brought to light by our advocates how important they felt it was that all of these programs stop acting as individual programs and start sharing and cross-working, because that, for most people, they just want this service, and they want the service in the way that they need to have this service. They don't care who delivers it. They just want to make sure they get it. And the summit really brought to light how stakeholders felt about different entities not playing with each other well in the sandbox, so to speak. From that summit, we developed many of the performance outcomes that have brought us here today. And the summits impacted really a broad range of disability groups as well as seniors. It was held in 3 different locations, in Reno, Las Vegas, and Elko. And it brought a tremendous number of stakeholders, providers, and just interested citizens to the table to talk about where we were going and how we were going to get there. And so I would say that the integration piece of this has been well vetted with our advocates
And do
and
you-
with the consumer.
And may I ask, I mean, do you think that it's been well received? Would you say that the vast majority of your stakeholders agreed with the integration?
Jane Gruner, for the record, from the conversations that I've had, I would say the majority agree that we need to do this. I think people are nervous because anytime you start changing the way funding works, it's a little nerve-wracking. They depend on assuring that their programs are stable. So I would say that most consumers would want this to happen as long as, in the end, there's a stable funding source and that the programs and services that they need are continued.
And Ms. Gruner, you just said something that piqued my curiosity, something along the lines of they just want to make sure they get the services. They're not as concerned about where they get them, and I find that contradictory to all the emails and phone calls that I've gotten from folks, because they want to make sure that they do get the services, but they also don't want to be given a lesser level of care. And they want to make sure that the person who's delivering the service is actually qualified to deliver the service. So I haven't gotten the concerns of not being able to get services. The concerns I've received are getting quality services. So I think we want to be very careful about statements like we just want service, because I don't think that's necessarily, it's not just I'll take it wherever I can get it. It's, I want to make sure that the services my child are getting are good quality services too. So I just want to be real careful about those types of statements.
Jane Gruner, for the record, there was no intention. I would be, I guess I have to say that I would only hope that we deliver quality services.
And I think that's they
when
want
I
to make
s-
sure that goes on.
But I do think for most families and for most consumers, the issue isn't that they get the service from early intervention or they get the service from developmental services. It's that they get the service and that they can count on the stability that the service is going to remain and that the service will be quality and that they don't have to jump all over the place to figure out which door they have to knock on in order to get the service.
Any other questions, Mr. Sprinkle?
Thank you, Madam Chair. Have you guys identified what kind of impact this is going to have on the budget in the future, on the general fund in the future, if this consolidation does happen?
Janet Murphy, for the record. With the consolidation currently in the budget, probably most of the impact is in the support services. There were no changes truly in the program side. So with the consolidation, we're bringing together some of our support services, and that's the area that's growing. We're instituting a cost allocation, and this year, actually, with the cost allocation plan overall, ended up with savings to general fund of a couple $100,000 over the biennium. We're going to be tracking it carefully. It's difficult for me to look at this point because we're just starting with the cost allocation and identifying where the funding sources should properly pay for these support services. So it's difficult for me to say in the future the impact, but I do know that this biennium, instituting it, there was a slight savings in general funds with it. Okay.
Thank you.
Any other questions? Being none? Okay. I believe that takes care of 3151.
So continuing on page 20, This is budget account 3156. This is for our senior and disability RX programs and our dental assistance program. On E225 is a one-shot request for updating migrating our senior and disability RX database to a newer version of SQL. And we did some pricing of the amount of hours it would take to update this particular database. On the next page, 21, we're talking about E275, and this funds our dental assistance program. Anyone at the December IFC would remember that we requested permission to begin a dental assistance program, and we were very clear and heard that we needed to make sure recipients knew it was a pilot, that we were going to see and potentially request additional continuation of the program in our budget, but otherwise they realized it could end the end of June. After we received approval, we had a contract approved in February. Valentine's Day was a nice day for our dental program. And we had staff that sent out letters to all our recipients under Senior and Disability RX, and we did have our 800 participants within 10 days. And we have a waiting list of 324 right now as of March 8th. So those individuals are signed up. We did our first eligibility load, so they have their cards and they're ready to access dental care. We are working with the Health Division on this program to do an assessment of the clients or recipients served so we understand their general dental health concerns and access issues. And we do have self-assessment surveys we collected from all the people applying. I don't know. I'm assuming there'll be questions on this one.
Yeah, definitely on senior RX and dental benefits. So we'll go from there. I think you've pretty much covered that part of it. So we'll go ahead and open it up for questions now, and that'll probably address some of the other things you probably would have said anyway. So, Mr. Kerner.
Thank you, Madam Chair. I recall the IFC meeting, and it was a concern for me at the time because it was a brand-new program, and we have so many other programs that we're only partially fulfilling the need. And here's another program that it seems like we're proportionately not filling the need as well. And it's a pilot program. Will we have any data before we finalize this budget in terms of, other than there are so many people that signed up, but any success or not success, or we're going to be able to, with the additional funding, be able to service more people? I mean, just give me your thoughts on that, if you would.
For the record, Tina Gerber-Wynn, I hope we have some information, but it will be pretty close to the finish line of this whole session because people have to have appointments, be assessed, seek treatment, and then we have to pay claims. So I'm not quite sure what information we'll have, but we do have reports from our vendor that we can share, as well as the Health Division is working on evaluating the self-assessments and some of the results of the treatment. So we will deliver whatever information we have available to you all as soon as we know it, as upon request.
Mr. Kerner, go ahead.
Thank you, Madam Chair. Just as a follow-up, this is a pilot program. I think you're putting in the budget funding for 2 years. Would it be better, theoretically here, to budget only 1 year so then now you have a year and a half of experience, then come back to the Interim Finance Committee, rather than budgeting a pilot program for 2 more years?
For the record, Tina Gerber-Wynn, my suggestion, my hope would be that it would be funded. It's difficult from a contracting perspective, also from an enrollment perspective, administratively, to continue this. if we were to report, which I'm assuming we will, about the progress of this program, we can tell you the outcomes on a regular basis. So to me, administratively, it creates some problems with contracting to not have a longer-term commitment for the program. I would say for our autism treatment program, it makes it difficult to solidify the infrastructure to give you good information unless we know we have the financing to create that information sharing, that reporting, as well as delivering services. You can.
Now, it's the traditional senior RX and disability RX coverage are fading into the sunset as of 2014, correct?
For the record, Tina Gerber-Wynn, actually, our program will be in existence if the donut hole closes through 2020. So we are funding prescriptions through catastrophic coverage for Medicare recipients. That hole doesn't close until 2020. So we'll see a decrease in use of the program, but it will not completely go away until 2020.
And the provider that you have will be able to give you utilization rates as we work through this, and I know it probably takes about a year to get utilization rates, so that will be part of what we'll be discussing in the future also.
That is correct.
I guess I need to understand the idea behind the subset of clients that are going to be receiving these dental benefits and the discussion of the first come, first serve, and no real medical or eligibility type requirements. We know some folks with certain diseases are more prone to, that dental is more important to their health in the long run than other folks. So I'm a little concerned about the first come, first serve aspect of this and the fact that there are 300 people waiting, and if any number of those are serious heart patients, oral health and heart disease are intricately linked. So I'm a little concerned about that, if we could address that.
For the record, Tina Gerber-Wynn, I figured that question would be coming, and we do have information. We'll receive that information again as far as a year to trend and look at these things. It won't take us that long to look at who's utilizing the program and collecting information on their health status. So we'll work with the health division to come up with or to refine our access to the program. That definitely is on the list of things to do. I don't know if it's on the timeline, but I'm sure it's implied somewhere in that timeline of what we would like to do to hone the program and target it to those individuals who are at most at risk health-wise.
And then when we get into the maximum benefit amounts, the co-pays, will they be analyzing those folks who bump up against the maximum and what services they may not have received, what services may not have been accessed because of the 50% copay on major services? And then I guess I just really want to understand I'm not sure if we want to go to actual means testing, but I think we want to make sure that the folks who need the most amount of care with the least amount of means actually are able to access care, that they're not put in a position where they're set up to go to a dental appointment, but yet they don't have the means to pay for the services that they need. So I think there's a number, and I'm not sure if your contractor's going to be compiling all this or how all this data is going to be evaluated. Are we going to be doing exit interviews with the participants to find out where the glitches were for them, so that as we move forward, or if we move forward with this, we make sure the appropriate people are getting the appropriate care with the right amount of resources?
For the record, Tina Gerber-Wynn, you just described our quality process. We keep talking about quality, and that is exactly what we do with programs for the same reasons you're noting. How well are we doing? What obstacles do people face? It'll be a joint effort with the health division staff, with our own staff, and with the vendor and their reports to project what is happening in the program, to come up with altered strategies, better ways to address the client load. And I know we have another decision unit we're going to talk about in a minute about the staff serving the program. They are assisting people with accessing benefits other than our programs every day. We have 2 staff who are on the phone constantly helping people find other services. And we do use community level services for dental. It's always been an issue for our state. It's been hard to access. Ever since I started, which was a long time ago in the field, you couldn't find dental services for people. So this is the beginning, the tip of the iceberg, but that's where we're working on right now to assess better access to the program and to give you information on where we think it's going to go with service demand. We don't collect that information right now because we don't have a program that requires us, and I don't mean to be required, but it's not something on our radar because we're not answering a lot of dental questions. This will give us an opportunity to collect for more information about what's happening with seniors and people with disabilities trying to access care, specifically in relation to dental.
And I understand that it's been an issue for the last 12 to 14 years that I've been around. It's gotten a bit better in the last few years, especially in the urban areas, but it's still very, very difficult in the rurals, and we understand that. So I think you've answered most of my questions. Mr. Sprinkle, sure, go ahead.
Thank you, Madam Chair. Just kind of a follow-up to the copays. I'm just looking through my notes here, and it looks like we've assisted some people in copays for dental through the reserve funds, yet those monies don't roll over if there's any excess. It goes back to the original source funding. So I'm just wondering if maybe this is something that we should actually be budgeting for to continue to assist these people.
For the record, Janet Murphy, you're absolutely right. We've asked for a copay assistance account, per se, that we can help people up to $500 to help them with their copays. And our original thought when we were preparing the budget was to hold a reserve, so not knowing how people will access this account, that could roll from year to year. But after further analyzing that and the changes in the tobacco statutes, we realized that what we need to do is budget for the copay assistance. And I would like to work with your staff to we can identify that.
Thank you. Yeah, it seems like it's probably something that gets utilized a lot, kind of dovetailing off of what the chairwoman was saying. So it seems like an important part of this.
Janet Murphy, I would agree. I think when we were first planning this, this is all new territory in budgeting, and so we weren't sure, but I agree from the questionnaires the self-questionnaires that we received, yes, there's definitely a need for the copay assistance.
On the access to the contingency account, if we could address that. These are tobacco settlement funds, yet we're leaving an opportunity open for access to the contingency account, if we could discuss that.
Sure. For the record, Janet Murphy, it's what I think we've just been discussing. It's the dental program and it's the copay assistance. This is new territory for us. We don't know the need, and we just needed a safety net to be able to come back to you and let you know what's going on with the program and if we had a greater need for that.
Okay. All right. That addresses that. I guess we should go ahead and move on to a couple of the last items that are there, and I think we should be able to breeze through those pretty quickly.
So on page 22, did I skip a page? No, you're good. Cool. On page 22, the E710, again, talking about replacement software and hardware based on the EAT schedule. The E804 is our cost allocation acknowledgement in this budget. E805 is a request to reclassify the Administrative Assistant 3 to a Family Services Specialist 2, and the Administrative Assistant 4 to a Family Service Specialist 2. And I had mentioned earlier these staff who address the calls and eligibilities for this program, Senior Disability RX, and now the dental program. I wanted to note that there was an error in the step that was noted in the budget. It's supposed to be a step 1 instead of a step 8. I believe that will create some savings in our request. So I wanted to acknowledge that, and we'd be glad to work on that with whoever we're supposed to work on that with.
We thought that was a boo-boo, so, yeah.
And let's see, if there's any questions about that, we would work with state personnel to assure the classification is correct.
And through personnel, you would examine the duties and figure out what the actual position would truly need to be, whether it's a family service specialist or whatever the classification needs to be.
That is correct.
As far as these positions go, the being able to actually do the eligibility for these and the complexity that's involved in figuring out where folks actually fit in this continuum of services. How is the eligibility analysis going to be done?
For the record, Tina Gerber-Wynn, if I understand your question, how are the staff trained to understand the different parameters of the program?
It seems to me that, yeah, I think you've probably phrased it better than I did, so yes.
We do have procedures for the staff to understand the eligibilities. We also work with the Division of Welfare and Supportive Services for them to be trained on welfare eligibility requirements, so they understand what Medicare savings plans individuals might be eligible for other than this program, or Medicaid benefits. Additionally, these same staff are trained through the Senior Health Insurance Assistance Program to understand Medicare benefits. So they're trained up. They learn a lot of different things so that they can then triage, or maybe that's not the right term, but put the person into the right program. So they are trained on a variety of services and eligibilities to understand the nuanced differences between the funding, income requirements, et cetera. So they've been trained to recognize that.
So they can do a thorough evaluation of the case before them and make sure that they get all the appropriate services, even ones that they may not have thought of, the client may not have thought of before.
Absolutely. That's what we do. That's their
Okay.
life, so absolutely.
Righty. Okay. Any other questions from the committee? Seeing none? I'm sure we'll be hearing more about dental. It seems as though my whole career has been about dental, so it's happening again. I think we can go ahead and move on to 3266.
Okay. For the record, Tina Gerber-Wynn, I haven't said my name for a while. 3266 is the home and community-based services budget.
Maybe we should just give everybody a number and then just, number one speaking, number two.
Well, I thought the other two were short, so this is the longest one. This has the most decision units, so
Okay.
we're ready, right? This one is our home and community-based service budget. The first decision unit I'd like to talk about is our M200, which is our caseload growth for our home and community-based waiver program. Just for people who are new to this, our home and community-based waiver allows people who are nursing home level of care to receive assistance in the community and become Medicaid eligible. Our staff do a great amount of work to make sure people have a functional need for care. They need assistance with personal care or transferring, assistance with cooking, et cetera. And also we help them with the eligibility requirements for Medicaid, which are also complex. We are asking for additional staff for this program for caseload growth. We are expecting 118 new recipients to this program this biennium, as well as we wanted to add this staff to assist with the oversight. We do a lot of work to facilitate entry to this program. We have about 30 to 50 people leaving every month due to institutionalization or death. So we're constantly processing cases. We're recruiting for people to provide services in this program. So the staff would be addressing caseload growth as well as assuring we can continue to address the requests for care, because we do want people to come in and wait appropriately, but shorter lengths of time. The wait time for this program is 67 days. I think that's actually quite great for us because of the number of cases we have coming in leaving this caseload. And we do work with Medicaid on this one to project our need for this caseload. And I don't know if you had any particular questions about that.
Now, are these new waiver slots then? I know you have new positions.
Correct. We asked for 118 through the biennium. Medicaid is working on a Money Follows the Person grant, and they are looking to move more people out of institutions. So we're partnering with them to make sure we have availability on the waiver and prioritizing those people leaving institutions. So we're projecting that they will find an additional 118 or so people to serve. So we want to be able to accommodate those.
So we have to have approval for those waiver slots. How long would it take to get the approval?
We would definitely have to have approval. We work with the Center for Medicare and Medicaid Services, and we project the number of people we'll serve in the waiver annually. We can create an amendment to them to advise that we are planning to serve more people. If we find out that this is a positive, it's a go, we can let them know, and they turn around the request within 90 days. Because we're not projecting a reduction in services or a change in eligibilities at all, it's a simple request to the Centers for Medicare and Medicaid Services, and I wouldn't expect that it would take more than the 90 days.
And you would be able to fill positions before you actually got the approval?
We would not be able to fill waiver slots until it was approved. We build in a duplication, meaning we have people coming and leaving the caseload. So we always project a slightly higher unduplicated count. So we do have some flexibility with that until we are approved for additional participants.
Right, but as far as the new positions, the 7 new positions, would you be able to start ramping up those positions in expectation that you will get the approval of the slots?
Absolutely. We're always ramped up. State personnel has an ongoing recruitment for social workers, another old theme. People leave state service for more money, and we are constantly recruiting and interviewing and filling positions and training staff.
Okay,
It's
and,
part of what we do.
alrighty. And these new slots will impact a wait list?
We expect that our wait list will stay the same, meaning 67 days or less. So it will improve access for people, yes. It will help keep us on that mark.
And this is not a required program, so do we consider this as an enhancement, or?
Oh, will you answer?
Sure, I'll answer that.
Hate to throw you a curve.
I know.
there, but,
That
we're
was
going
a
to give
curve.
Tina a break for a
That was a
moment.
curveball.
Number 2 speaking. There
Number
we go.
2 will speak. For the record, Janet Murphy. We considered a caseload adjustment in that we've been approved for caseload adjustments through the budget office for this program, for our CBC program. So that's why we placed it in an M decision unit as a maintenance.
Alrighty. Any other questions from the committee? Senator Kickover.
Thank you, Madam Chair. So when you submit a waiver amendment to CMS, is it specific to the waiver program? For example, is the home and community-based waiver amendment potentially different than something for like the assisted living waiver?
For the record, Tina Gerber-Wynn, all the waivers are separate documents, so yes, it would be a different document submittal to CMS. We don't work with the same people it's a different group of people who approve the waiver amendments versus the state plan Medicaid amendments, and I know there's been some concern that they've taken longer to approve. It's a different set of policy people
That's good.
who work on those approvals for the waiver.
So let me ask you this. We're seeing a funding maintenance of 54 slots in the assisted living waiver because although only about half of them are filled over a maintenance of effort requirement, are we not able to go back in and submit an amendment to reduce that, so that we could redirect some of that money into another area if we've got all these, we're budgeting for slots that aren't being filled?
Tina Gerberwin for the record. Thank you for the question. We could go in and request a reduction in the assisted living waiver after January of 2013, I believe, or
That's
but
now.
it is under a maintenance of effort requirement right now because of ARA. Tell me what that acronym means again. American Reinvestment Recovery Act. So there is a maintenance of effort for the waivers right now. I want to say for the assisted living waiver, we have worked with the facilities. There's 2 in the state, and they did have administrative changes and didn't really understand the complexity of the program that we operate. So we're working with them and have actually identified 16 people who are potentially eligible and should be eligible in the next couple months. So we're hoping to get up to the 54 range.
Okay, so the caseload projection on that waiver is going to increase, but it's already budgeted, basically. Yeah, okay. All right, thank you.
Mr. Sprinkle.
Thank you, Madam Chair. Just back to the home and community base for a second. You kind of piqued my interest there. You were talking about a constant need for social workers, but it looks like EPS is also part of this. Is there a chance that with the increased caseload, you could transfer positions or help out with this increased caseload that you're projecting?
For the record, Tina Gerberwin, our Elder Protective Service Program does have vacancies currently. I believe your question is, could they assist with community-based programs as well? We do cross-train staff, but we do have a staffing ratio for each caseload, not to get all technical or act like a bureaucrat, but the reality is we have to have reasonable caseloads for our staff to respond to requests. For Elder Protective Services, we've worked a great deal to come up with a proper or an appropriate caseload ratio of about 1 to 40. They have an obligation to investigate within 3 days any complaint of elder abuse. And that is, no matter what the situation is, we have to investigate. So 1 to 40 keeps them very, very busy. They have 2 or 3 referrals a day to investigate that are new, as well as address issues with the older cases, the cases that they've already received. So that's a manageable caseload. We did studies, 1 to 25. It depends on the state you look at. So we settled on 1 to 40. The staff we're asking in the budget would allow us, based on our historical projections, to stay around that level. So while we have vacancies in Elder Protective Services, again, we're filling them. Every week somebody tells me that there's somebody new leaving, and it's generally related to payment. For community-based care units, so again, we have a caseload ratio. We're trying to acknowledge our intake process with a ratio because we do a lot of work. We might have 100 referrals. We have to help all those individuals understand what they could be eligible for, whether it's our program or another program, and about 50 to 60% of them come onto our program, but we want to help all 100 of those people. We can't not help them, so that's why we're trying to add the CBC staff, the community-based care staff, to address that intake process.
Any other questions? No? Seeing none? We'll go ahead and move on.
Okay, so on page 25, we gave some caseload information on our community options program for the elderly. That's a small state-funded program that mimics our waiver program for people who have a little bit of a higher income, but they are not yet Medicaid eligible. On page 26 is our assisted living waiver program, and Ben asked me about that, so I answered some of those questions. I don't know if you have additional questions about assisted living. We wanted to give you some of that information on our caseloads. And then on page 27, the next enhancement unit, or an M unit, is an increase for our assisted living and assistive technology program. We're asking for some additional funding to address our wait list. This program, we partner with the Department of Education, Training, and Rehabilitation to assist people to access technology and home modifications to remain independent. So we have 2 vendors, North and South, who are contracted community providers who work to assess needs for people. Through this budget, we address home modifications like a bathroom remodel, might be a lift for a van, a vehicle so someone who is with a disability could drive, ramps so they can get in and out of the house, some smaller equipment needs to shower independently, etc. So this program has always had a wait list. We prioritize access to this program based on need, functional need, physical need, and risk for people being forced to move out of their own homes because they can't take care of themselves without these remodels or modifications. We base the budget on a 4% increase, looking at our historical requests for funds and a cost per eligible. We do track that. So I don't know how many people have remodeled, but sometimes when you get into a project, it turns out to cost a little bit more than you thought when you're remodeling a bathroom, et cetera. So these are essential remodels, however, it's not cosmetic. So we're requesting additional funding to reduce the wait time for those individuals. It will not eliminate a wait list for this program. I'd be happy to answer any questions on that.
If it won't impact, well, we know it wouldn't going to get rid of the list. I think that's a given, but how will it actually impact the wait times?
For the record, Tina Gerber-Wynn, we looked at the wait times. A lot of the time, the way we mark this program is when a project is completed. It doesn't really necessarily have anything to do with services not being delivered. It just takes a while for something to be finished. For example, installing a ramp, it might be to receive the 3 bids, pick the best vendor, and then have the work done. So it could affect the wait times, meaning we could get to people sooner, but realistically, I don't think the impact will be that large because some of those things are based on the nature of the work.
And
If
what
that makes
impact-
sense.
Yeah, and I guess learning about the Olmsted decision, we have to always keep that in the backs of our minds. Does this help us in that respect at all, or?
It does, because people who are coming to us are at risk to no longer be able to live at home. And it's reasonable for us to address their needs initially within 90 days. That doesn't mean the service is complete in 90 days. It means we acknowledge they need help and we're trying to process their case through so that they can be approved to have something completed for them.
I guess it would be helpful for us to understand when a project starts and when a project finishes. It's not necessarily the ending date, but it's the initial date to where we've actually recognized the need and taken the first step towards addressing the need. And then if it takes 2 months to complete the ramp, we understand that we started 2 months earlier. It's just not the final date, it's the first step date that I think would be interesting for us to be able to evaluate that, to look at the additional funding going towards making sure that first step date is earlier in the process. And that would address the client's issues. So I think it would be easier for us to understand. I understand finishing dates. It took my husband 3 years to finish 1 bathroom, so. And it wasn't his fault. It was mine. I kept changing my mind. So that's when we did the second bathroom, we hired a contractor. So. And then he had to deal with my change orders. So anyway, I think we can go ahead and move on that. We
For the
understand
record,
remodeling.
Tina Gerber-Wynn, I agree with your point, absolutely. And I would refer back to page 5 where we talked about our need as an agency to give you consistent caseload projections and information, and that includes data points and explaining those. No program will ever be exactly the same in measure, but we know we need to keep it simple so that we can explain it, because it's hard for us to explain and it's hard to receive sometimes. So
Okay.
absolutely agree.
All righty, thank you very much. So we can move on to the next one.
Yeah. The next is E275, And this funds services for our Autism Treatment Assistant Program. We serve children with autism spectrum disorder. And in this budget request, in state fiscal year 14, we want to increase the caseload from 137 to 236 families served, and by the end of the biennium to be serving 341 families and children. I wanted to say that on page 28, we did show the funding mix. This is funded by general fund as well as tobacco monies. We need to acknowledge that this budget request will not clear a wait list. It will address the highest priority cases on our wait list. Our common theme is intake. We assess people, try and help families understand services and available solutions for their child. And some of those individuals go onto the wait list and some do not. But we assist all families requesting information. So this budget unit does not clear the wait list.
Senator Smith, please go ahead.
Thank you, Madam Chair. When I was looking at this budget last night, I was thinking about how every session I've served here, the autism lack of funding and discussion has overwhelmed us. And it's so good to see that we have made so much progress. I'm assuming, I see Ms. Crandy and others in the audience, and I'm assuming that we may hear some comment from them, but it seems that we're making some progress, and I just wanted your observations about whether the moves that we made last session to consolidate and the fact that we've better funded. I don't like it that we're still going to continue with the wait list, but we've made so much progress considering that these rooms used to be overflowing with people concerned, and we would leave these hearings in tears because we weren't able to do enough. So I wanted to say first, I'm so glad that we've made progress, but I wanted to hear your observations on this transition over the last 2 years.
For the record, Tina Gerberwin. We have worked very hard on this program to solidify tiers of service. To us, it was a pilot project for several years, and now it was formally acknowledged in the budget, and we appreciate that. Our staff have worked very hard to identify how to address service needs on a comprehensive level and also wrap around private insurance. We're working with the Division of Insurance so that we can help people gain access to their private insurance, which has been a challenge. It's a change in the system. We talked about that earlier. We've advocated for that change. We have case managers who are skilled at understanding how to get to those insurance benefits for people, as well as helping them find providers for some of the behavioral assistance. We've been asked about projecting the cost per eligible, and one of the things I would say is that as the caseload grows, we'll have a more stable cost per eligible, but one outlier can really create a lot of difference in what we're paying on cost per eligible in each tier. We have comprehensive, we have specific skill set, levels of care we're trying to build. So it's been a great experience working with others within our department, specifically people at the developmental services agencies as well as the health division, to come up with a plan for recruiting providers, for understanding some of the complex needs with children with autism. And we've joined together as divisions within our department already to do that. So we've worked on that, being able to transition from program to program, again, going back to our overall plan for the agency. So it is an ever-growing issue. If we have enough staff to give people help and information before they enter our services, that's what we're really trying to do, as well as obviously take them into our service delivery model if they have no other alternatives. So it's been a lot of work, but I can tell you, and I know people will talk about the passion they have for the caseload. I know Jan's here, and she will. It's been a rewarding experience. A lot more work to do, however.
Mr. Sprinkle, go ahead.
Thank you, Madam Chair. I think there was something that you just said that was a little confusing to me, so hopefully you can kind of clarify. When we're talking about costs, you said that you're anticipating it becoming relatively stable. Yet, with all this transitioning going on and the different mixes that are going to continue to occur with the needs and so forth, I'm just curious how you're able to project that it's going to be stable. What are you doing right now to monitor the costs so that you can say that? I just don't think I understood that.
For the record, Tina Gerber-Wynn, what I'm trying to say is that we could predict a cost per each tier level. So as we have more expenditures and history with the program, we'll get better at predicting the cost per each level of care. It's new to us, the formal billing portion of it. We were able to have a vendor now to pay for claims for our behavioral interventionists, and so we have better data to project on as far as cost. We just have more years in on tracking the cost of the program. One thing that isn't unknown, though, is with healthcare reform, how that will affect this. But again, if we have people who can help our clients, people requesting care, get into other forms of care and insurance, that would affect the cost for the program. So maybe I shouldn't have said it. We'll have a better idea. I think we'll have a better idea of telling you what will impact our cost, not exactly a cost per eligible. It will be depending on the individual and what they bring into the service, other insurance, et cetera.
Well, thanks, and I think you actually just kind of got into another question I was going to have with the expansion of the Healthcare Act. Can you kind of go into that a little bit further and talk to me about how that is going to affect the services?
That's unknown. I think the reality is that healthcare reform will create access for people, but the essential healthcare benefits may or may not cover behavioral services. Our state does have a law that requires insurance companies to fund certain levels of service for children with autism. And essential healthcare benefits may also include some of those items, but that's individual. So to predict for what my insurance would cover and what someone else's would cover, it depends on the plan. So again, we'll have to be experts in figuring out which door to knock on. So healthcare benefits will be available, but a lot of the services, and thank you for the opportunity to say, a lot of the services we provide aren't under essential healthcare benefits. They are over and above. They are not common services. We're special is what I'm saying.
Thank you. That definitely helps explain.
And we understand you guys are not actuarials, and figuring this out, we're going to have to base it on history and utilization. And like you said, one outlier case can really throw the numbers. And I know the insurance commissioner and the health exchange wrestled with this particular issue. I was in a couple of the meetings trying to figure out how we were going to address this, and then the Affordable Care Act with being able to cover your children up to the age of 26, and then the mental health care component and all the other pieces of this puzzle will make it difficult to figure out in the future. We're just going to have to work all the way through it. How many children are currently being served right now, though? I don't think I've gotten a recent number lately.
Our budgeted caseload was 137, and we're at 137.
Okay.
So
Yes,
that's
Mr.
on page 29.
Okay.
I'm
I
a
was
time-
still on page 28.
Yeah. that's-
Alrighty.
So I'm a
Senator Kickheffer, did you have a question? I'll go to the senator and then we'll continue.
I'm sorry. Thank you, Madam Chair. So, with all of the variables that we've talked about in terms of the cost per eligible and all that, how much does it cost to eliminate the wait list?
Okay.
Sorry, I'm just to be blunt about it.
You want to know
we-
the number, you have to ask.
Okay, we looked at this with the budget office during the governor's phase, of building the budget. And to eliminate the wait list, we estimated about $5 million
Over the biennium?
over the biennium.
Okay, thank you.
Good question. Okay. Do we have a second? No. Okay, no, let's, don't get me in trouble with leadership now here. I'm already on probation, so,
So page 30, for the record, Tina Gerberwin. I am a timekeeper, and I keep looking at Janet's watch. We have about an hour and 15 minutes left, and I want to respect developmental services because I know there's quite a bit in that budget.
Right.
So I'll quit telling stories, and I'll try and talk faster. Page 30, E710, we talked about hardware, software. E711, we're asking for voicemail for our phone system in Reno, so we can also receive voicemails and call on the phone. E804 is the cost allocation recognition in this budget. On page 31, we have E805, and in this, we're requesting a reclassification of our Social Service Manager 1 to a 2 in the Elder Protective Service Program. And a Social Worker 2 position, we want to reclassify into a Social Service Manager position, a 2 as well. This matches the infrastructure we have in our Home and Community-Based Service Program, where we have a manager north and south to oversee the day-to-day operations. Talked about that briefly based on a previous question. This is a issue of growth that we assume some responsibility from Clark County to investigate elder abuse allegations in 2010, and we were able to receive staff, and also in the last budget we received additional staff, but realized we needed a manager in Southern Nevada because we have the largest number of staff there and no on-site manager. We really have expended a lot of time and effort to develop the caseload ratios as well as training and additional services to address the needs of elderly people who are vulnerable to abuse, neglect, and exploitation, and offer some services to mediate the most immediate concerns that or issues they have. So this request, again, we'll work with state personnel to work on the reclassifications, but it is in line with how we operate our current programming through Home and Community-Based Services. It will mimic that structure. And I would be glad to answer any questions on this one.
so you're requesting a Social Services Manager 2 in the north and the south?
Correct. We have one manager in the north right now who's a level Social Service Manager 1. We're asking that to be upgraded 1 grade because of the complexity of the caseload as well as additional duties to the policy and program development. And in the south, it's sheer numbers. We have added so many staff. It was 1 unit of 7 people, and now it's 4 to 5 units of 5 to 7 people. So it's quite large. Again, going back to page 5, program growth, we really have had such a large program growth that we need administrative staff to address issues with the caseload, meaning things that come up regularly in the course of doing business. We have a lot of activity with this caseload.
It just seems to me as though with the ratios that we're looking at, the numbers we're looking at, 1 in the north and 1 in the south, it seems as though there's a heavier workload in the south.
I would suggest, going back to the distance issue, we always come up with this statement too. Our northern manager will be working more on the policy development and some of the contract issues that we have. We have other services. I shouldn't say issues. We have contracts for services. That person will be helping facilitate access to specialty providers for psychiatric evaluations as well as temporary placement. So the northern manager will be in charge of that, whereas the southern manager will be addressing the daily operations more heavily. Northern manager also covers Elko, so there is greater distance for that one. So we level it out, but we work both of them hard. We'll work both of them very hard.
I have no doubt. Okay. All righty. Committee, any other questions on that particular issue? Seeing none? Okay, you can go ahead and move on.
Okay, page 32, E900 and 901, transfers positions from budget account 3151. Basically, it's cleaning up to putting those positions in the right budget category. And so that's the end of 3266, unless there's other questions.
I believe we had a question on, making sure I'm keeping, yeah, the traumatic brain injury, the technology project that's been planned for 2014 and the funding on that. That would typically have been used for rehabilitation, and it's being directed towards an information and technology project. So I think we want to understand the switch in those monies.
For the record, Tina Gerberwin, we do have and have spent a lot of time in the last 5 or 6 years in developing a consumer-facing website, a portal. I don't want to get all techie, and I'm sure I'll be corrected if I use the wrong terminology, where we have passed on a lot of information and assistance to people based on certain medical conditions. We have information on respite, which has been a big federal initiative. We have information on our senior health insurance program, information on a variety of services that are available to people who are caregivers, training and learning modules so people can understand how to provide care. What our recommendation is to utilize this system to advise about traumatic brain injury. A lot of what we're hearing about traumatic brain injury is that it's undiagnosed in older people. It's not recognized. It might be disguised as some other illness. And really, people want assistance on how to deal with care delivery, behavioral issues related to that. So our suggestion and our request would be to add to that infrastructure. We cannot possibly serve everybody who has a traumatic brain injury, but we can help family caregivers and individuals serving those with traumatic brain injury to learn at least where to start providing care and getting ready for whatever's coming next. So that is our request. It's in line with other things we've done on the portal. We have experience with that in developing these units for other programs. So we have historical experience with development of that information sharing, which ad nauseum I've said our job too is to help people get to care, not necessarily provide the care. So that's what this project is for. Additionally, healthcare reform, we're suggesting there will be an impact to this caseload, that people will have additional benefits so they will not have to use our current service delivery system as much, but we are modest in suggesting that it will be eliminated. As far as a need, we still will have to deliver some care. So we're projecting a slight increase in the second year of the biennium as healthcare reform becomes more evolved.
And
So
I guess my question is, this money is used for folks that had no other payer source as far as rehabilitation goes. So if we move money from that to the technology side, who's not going to be getting the services? And those services within the first few months of someone having an accident or incident are very important to the long-term recovery of that person. So I'm just concerned that we're shifting monies to technology and away from care. And I think care should be first and technology for the other folks after. And I have some concerns about who will not be getting care.
At this point, we don't have a waiting list for this program, and it's been stable as far as the access to care. And so we are projecting that it will diminish access to care. We're hoping, or our intention is, to improve access to information that assists a caregiver and helps the individual plan for their care. This service is generally at the end of a rehabilitation path. It's not at the beginning. Insurance generally covers the beginning of an injury. It's the lingering effects that we address through this program.
All right, good. Okay, thank you. That makes it clear. Mr. Sprinkle?
Thank you, Madam Chair. Just curious, how many people are we currently providing this for?
do have caseload information, and I'm sorry, I have this binder full of many things, but I don't recall that I printed the caseload.
I don't have the caseload, but what I do have is that in FY12, so last fiscal year, we served 51 individuals.
Are there any other questions on this particular budget item? I think what we're going to do is, since autism is such, I mean, there's been so much about it in the last couple of years, that we're going to go ahead and open it up for public comment on the autism portion of this, and then we'll come back and start up with the IDA Part C. So we'll go ahead and open it up now. So anyone up north or down south who would like to make public comment on the autism portion, you're welcome to come forward. Ms. Grandy, I'll go ahead and let you start, and then we'll go to Southern Nevada. Welcome to the committee. Nice to see you.
Thank you. Nice to see you too, Madam Chair and committee members. For the record, my name is Jan Crandy, and I'm the chair of the Nevada Commission on Autism Spectrum Disorders. Mary Liverati was here too, and she was going to join me up here. I think she stepped out for a bathroom break. First, I would like to express my gratitude to the legislators and Governor Sandoval. Your continued support of the ATAP program is changing lives, so I am grateful. Last session, additional funds were provided to support the foundation to build a database specific to ATAP. The program currently operates with only one state staff position, a program manager. As the program grows, I believe that the program would benefit from at least one additional staff person to promote the program and to help manage the wealth of data the program is collecting, data which will provide valued information to the Commission and our state. The program collects data for quality assurance and to demonstrate progress quarterly and annually on 64 impact targets and to track intake and exit assessment results. The lucky 137 children currently being served by the ATAP program are making dramatic improvements. Parents and caregivers are being trained and becoming active members of their child's treatment team. Research has demonstrated that 47% of children who receive early and intensive levels of treatment can reach normal functioning. It is with honor that I can report in 2013 a number of children will and have started the transition to exit the program. Because of treatment, these children will no longer need services and are attending school in regular education classrooms. Recent assessments on several of the children demonstrated IQs in the normal range and normal functioning across all domains. These children achieved best outcomes. 3 of the children now present in the non-autistic range in the autism rating scales, and this was done by outside clinicians. The Commission was pleased to see the Governor increase the funds to support approximately 100 additional children. Currently, there are almost 300 children on our waiting list, with the majority waiting more than 1 year to be served on this program. The maximum wait time is 1,974 days. Due to capacity, the program is not actively even promoting the program, and still the wait list increases by an additional 10 children each month. Every day a child waits to access treatment, the possibility of that best outcome in an independent life becomes less likely. A 2003 study demonstrated this fact. A waitlist group of children regressed in all areas, including cognitive ability, an average loss of IQ of 6.7 IQ points while on the waitlist for 1 year. The majority of children could not catch back up once treatment started and were reassessed after 1 year. I do understand that there's limited funds in Nevada's budget, but to think there will remain more than 200 children on the wait list, children who have and will miss the possibility of being one of those best outcome children, is wrong. This decision will cost Nevada in the future when we are paying for more expensive adult services. ASD affects 1 in 88 children, and recent reports say the prevalence rate is likely higher than that. Nationally, employment for individuals with ASD is about 6% for full-time employment. So we're talking about that we will be supporting the majority of these children for the rest of their lives if we don't treat them. Clark County School District numbers right now are over 4,000 that they have identified with autism. So to think that our state program is going to serve 300 kids it's very small percentage. And I can tell you, insurance coverage, I'm grateful that we passed that bill, but there are so many barriers. It is broken. It's still not working. Kids are not getting the coverage. They're not being able to access treatment hours at research levels. We have to fix this. And I do hope and believe bringing early intervention under aging and disability will lead to children under 3 accessing evidence-based autism treatment before they exit early intervention, or at least by the time they're 3-year-old. We're still not, ATAP's not serving those kids. If you look at our age groups that we're serving, very few kids are 3 years old and under. So thank you for your time, and I really appreciate you guys doing the last-minute video to Las Vegas, although I couldn't get back with a lot of parents after I told them not to come and make rearrangements. So thank you for letting them do that. And there's some parents that are there, and one of them is a grateful parent of one of those best outcome kids I just told you about. So thank you very much.
Thank you very much, Ms. Grandy. Ms. Liverati?
For the record, Mary Liverati. I sit on the Commission on Autism Spectrum Disorders. Just one quick thing on the insurance. One of the problems is the pool of providers that we have. The ATAP program has about 400 behavior interventionists, which are the ones that work one-on-one with the children. In the state, we only have about 40 to 50 that are certified at this point as certified applied behavioral interventionists. We call them CABIes for short. The insurance companies have to use CABIes if they're going to bill, if they want to bill the insurance. So we're working right now with the psych board, with the Division of Insurance, and with the health insurers to try to fix that. There will be a bill coming later this session, hopefully to help encourage more people to become certified so that we have more service providers. But that is also an access issue that we are seeing. So just wanted to bring it to your attention.
Okay, and I remember when we passed the original bill, the discussion around the certified, and this was one of the concerns that we had, that it was going to be one of the barriers we thought we were going to have to cross. So it's now shown up, and we're going to have to work on it and figure out how we can address it.
And the other issue is providers becoming in-network. Very few providers are getting to be in-network in an insurance company, so they're not able to. Families that they should have continuity of care and be able to stay with their same provider, they're either having to change, or the providers in Nevada, for instance, in Las Vegas, for HPN has only 2 in-network providers. Well, you can imagine they're inundated. They don't have the staff to serve everybody. So that is a growing concern.
And that gets back to network adequacy, and I'm not sure how that all works together. So we'll go ahead and go to Southern Nevada. Please introduce yourself for the record. Just push the button to turn the microphone on.
Good morning. For the record, my name is Kimberly Abbott. My son Ethan began receiving ATAP funding at a very crucial time in his life. He was a little over 2 years old and was diagnosed with severe autism. That was 3 years ago. 3 years ago, he refused to eat solid food. Today, Ethan has a well-rounded diet that includes fresh vegetables and lots of pasta. We don't have to worry about which restaurant we can go to anymore. 3 years ago, he couldn't speak or even babble. Today, Ethan speaks complete sentences and holds conversations, sometimes long conversations. 3 years ago, he didn't know how to play and lacked social skills. Today, Ethan plays with wild imagination and creativity and plays with his friends all the time. 3 years ago, he was an unhappy boy, unable to communicate. Today, Ethan is completely indistinguishable from his peers and loves little boy things like Legos and Star Wars. 3 years ago, Ethan was diagnosed with severe autism by Nevada Early Intervention on 9 separate occasions, as well as by a pediatric neurologist, a child neuropsychologist, an occupational therapist, and several behavior analysts. They all concluded that Ethan had autism. Today, Ethan is almost through his second full year of preschool in a typical classroom with typical kids who have no idea he was ever diagnosed with autism. The school district's multidisciplinary team has run a battery of tests and has concluded that Ethan shows little or no signs of autism. We recently arranged for a seasoned behaviorist to observe Ethan's preschool class to see if she could determine which child had autism. Not only did she not identify Ethan, but when shown Ethan's picture, she said she had ruled him out because he was asking the teacher questions, a behavior not found in kids with autism. So why Ethan? Why has he had so much success? My husband and I feel that our experience qualifies us to answer this question. The answer is this: there are 3 key ingredients that together maximize the possibility of success. 1, catching it at a young age. 2, constant parent involvement. And 3, financial assistance from ATAP, because treatment is most effective in a one-on-one setting provided throughout the day. There's awareness, involvement, and funding. Ethan's therapy peaked at 38 hours a week, and he is now down to 5 hours a week of one-on-one therapy. Today, most of his time is occupied by swim lessons, karate, and cooking class. They're all costs my husband and I are more than happy to be paying out of pocket as Ethan begins the process of exiting his therapy program and passing along the funding he has benefited from to another little boy or girl who right now is in need and desperately waiting for help. As parents, we were able to catch Ethan's symptoms early and be constantly involved, but without assistance from ATAP, Ethan couldn't possibly have come this far and be this ready to face kindergarten in the fall. Ethan will be in a typical classroom, and I know he will succeed. Thank you for your consideration.
Thank you very much for being here, and congratulations. Go ahead, sir.
Good morning, everyone. For the record, my name is Gordon Gilbert. I am a father of 2 children diagnosed with PDD-NOS, one high functioning, one a little bit more on the severe side. The one on the severe side has received the support of ATAP, the assistance treatment program, of course. As a family who receives benefits from these appropriations for these services, I felt it absolutely imperative that I shed light on some of the good that it can actually do. We talked about the troubles with insurance, and that's certainly something I've faced in terms of denials, appeals, and even when we did finally get the insurance to approve behavioral services for my son, it still only covers a small portion of what's absolutely necessary. Best practices for the treatment of autism, and it's been proven time and time again, require 30 to 40 hours of intensive one-on-one behavioral therapy, and unfortunately insurance is just not measuring up to that. Without the support of ATAP, we simply would not be getting the services that he absolutely needs at this juncture. Beyond that, ATAP provides a mean to augment, as I mentioned, the insurance, of course, for the small amount it does provide. Basically, we've moved from in between, let's say, 6 to 8 hours with private insurance up to the neighborhood of 25. That does not include, of course, services that he renders from the school, but it's those in-home services where we're seeing the most positive gains in Gage, who is my 5-year-old that is on the severe side. When I was without work for a short period, ATAP actually bridged that gap that I had in insurance, kept the continuity of services for him so he was able to maintain those behavioral services during that gap in employment and that gap when I did not have the insurance to cover those 6 to 8 hours that they currently do. Quite simply, without ATAP, we simply would not be providing my son with the best possibility of that best outcome that Jan Crandy did indeed talk about. Since my family received our first diagnosis of autism spectrum disorder, the prevalence of this neurological disorder has increased from 1 in 150 to 1 in 110 to 1 in 88. A study in Korea actually showed that 2.5% of the population will be diagnosed PDD-NOS. There's more underway. We mentioned only 137 are currently covered by ATAP, and there's more on the wait list. Someone mentioned what it would take to cover that wait list. I would love to see that happen, because the earlier we treat this condition, the greater the potential outcome. You talk about that some in terms of the early intervention. The long-term care studies show that it's anywhere between $3.2 to $8 million to care for an individual from age 18 to grave should they not get these services and not achieve that best outcome. On a personal note, my son, who was nonverbal until age 4, has been the greatest beneficiary of the ATAP funds. About a week ago, he actually approached me and initiated conversation, which for a child with autism is something that you don't see too often. And he actually said, "Dad, guess what? I'm all wet." First of all, I was overjoyed that he initiated the conversation. Then he said "Dad" to me, and he initiated that, which has only happened, I can't even count it on 2 hands for you. Despite the fact that he had actually flooded our bathroom, I could care less. The fact is that he engaged me, and this is a direct result of those behavioral services that he had received, and of course the ATAP funding that helped provide those services. Without them, I don't have my boy calling me Dad. Without them, a lot of other children are going to go by the wayside. It is an essential service. It is absolutely necessary, and I simply can't promote it enough. We're a middle-class family fighting uphill battles with insurance on a daily basis. It provides an extraordinary bridging gap, if you will, to cover those services which are absolutely essential. And as I mentioned, those numbers and those ratios that consistently increase, I might mention that the ratio is 2 to 1 boys to girls. We're losing a whole generation of young men to this condition if we don't treat it. Please consider the long-term aspects of this, and please fully fund ATAP and increase the funding and try and remove that wait list as much as you possibly can. Thank you for your time.
And thank you for being here today. We appreciate your testimony. Any questions from the committee? Seeing none, thank you both very, very much for sharing your stories with us today. It's nice to hear when we've done something right, but yet we still have more work to do. So we do appreciate that. With that, I think we could go ahead and move on to IDEA Part C. And if you want to give us a brief overview, and then we can, I think the major issue is just the how the compliance function is going to work. So if we can address that, that should get us through this one fairly quickly.
For the record, Tina Gerber-Wynn. I believe we're on page 33. Budget 3276 is for our IDEA Part C funding. Again, in this budget, we have the customary E710, E711, and 804s that acknowledge our cost allocation and need for software, hardware, and equipment. For this budget, it is the staff that provide the oversight for the early intervention services. Part C has moved several times over the course of the last 5 or 6 years in response to concerns of their role in overseeing early intervention services. The Part C office applies for the federal grant. We receive roughly, well, it was for almost $4 million. It will be reduced by 5.1%. And they also assure that our system meets 14 quality assurance measures, essentially making sure we get kids into service within 45 days, as well as having a qualified pool of providers to address the needs of children, assuring that there is development and growth in this child after the services are delivered. One of the things that has been questioned is how are we going to assure that we're properly judging our performance. We do this in other programs already. We've talked about home and community-based services. We have several waivers. We're obligated to provide quality oversight for those programs as well. The same staff do that. They're all in the same program. We assure that the provider qualifications are clear, the contracts are clear, our direct service staff oversee some of the on-the-ground work with the delivery of services. So it's customary. Again, going back to the growth of this program, I think we need to more fully acknowledge the need for our staff to understand those principles and to monitor the daily service rather than an annual look back, which is what the Part C office has been tasked to do. So we would do that as well as the day-to-day quality pieces. It's customary for it to be all in one. The rules of the program are complex, and the need to respond quickly is part of what keeps the system on track, and that is what we believe will happen with Part C and early intervention under one division. Clearly, the roles need to be more defined so we can explain them to you, going back to our lingo, but it is customary to have quality management and service delivery under the same umbrella. That's how we run.
And I think you understand the concerns about the appropriateness of, placing the service delivery and monitoring and compliance all in the same place, and I think we just need to be informed of what safeguards and what walls are you going to put in place to make sure that that independent monitoring of NEIS will stay at the highest caliber. That's what we want to understand.
For the record, Tina Gerberwin, I can appreciate that concern. We do use the university system to do they complete annual surveys of the participants and their families. That is independent of us. So we use that information to know where we are falling down or where we have areas of improvement and what people's perspective is on our services. And that has always been in effect, and we'll continue to use that information more fully, is my hope, as we go forward, to recognize where we need to improve. I think self-criticism is difficult, and improvement is definitely something we are concentrating on and acknowledge. But the parent survey is independent of us and will continue. And we have looked at other methods from other states, but at this moment, that is definitely independent of us, and there's other ways we can address this as we go forward.
Well, and I hope I'm not overstepping my bounds, but I just want to make sure that as NEIS changes and the discussion about private contractors come into play, it's very hard for the agency that would propose private contractors to be critical of their own proposal that they just made. So we do want to make sure that if there is a problem, we just want to address the problem. Making sure that it's objective and we look at what actually is happening with the children and the contractors. It can be difficult to address a problem that may have been created by something that you proposed. So we just want to make sure that whatever the problems are, that they do get addressed as we move forward in the discussions of the changes in the community providers. We want to build in those safeguards.
Jane Gruner, for the record, I did want to add that there will be a direct line of authority in separate areas. So Part C is under Tina Gerber-Wynn, and if this integration is approved, the early intervention program would be under Michelle Farrell, who is currently the Deputy Administrator for Developmental Services. Thank you.
And I don't think there are any other major issues with this, just the voicemail, the cost allocation, the computer equipment. So I believe we're good on that, and that completes that section, and we'll go ahead and start with developmental services, and realizing that we just have about 20 minutes, so we'll do as much of this as we can, and then right, so we'll need just a moment to switch staff around a little bit here. And we'll go ahead and start with the basic overview and get into a couple of the major issues, and then as we get into some of the others, we'll discuss them, and I know we're going to have to finish this another day. But as we talk about a major issue, we'll address that with each of the entities that it applies to, so we don't have to go back over and over again. We'll pick an issue, discuss how it affects everyone, and then move on to the next issue. So hopefully that'll be clear as mud to everybody, because it took me half of last night to figure out how this works. So please, go ahead.
Jane
Ms.
Gruner for the
Gruner.
record. Joining me at the table is Michelle Farrell, currently the Deputy Administrator with Mental Health and Developmental Services. Okay, we are on to the developmental services budgets. Currently in Nevada, there are 3 regional centers that make up developmental services. We have Rural Regional Center that covers all but Clark County, little pieces of Nye and Lincoln and Washoe. Otherwise, they have the whole gamut of rural Nevada. Desert Regional Center covers southern Nevada, Clark County, pieces of Nye, and a little bit of Lincoln counties. And Washoe County Sierra Regional Center serves Washoe County. Included at Desert Regional Center, they do have an intermediate care facility, which supports 48 individuals. The main services provided through developmental services are psychological services, family support, residential services through our supported living arrangements, and jobs and day services. Looking through this budget, you'll find that the overarching issue is caseload growth, and mainly that is from 2 bienniums of not having growth associated with their continued growing caseloads. Another theme that has come through is the complexity of the individuals currently requesting services and in the service system at this time. That is especially seen in the intermediate care facility in Las Vegas. Moving on to page 35, you will find the M200 caseload growth for the 3 regional centers. There has been a shift in population away from rural areas, with new growth located in the urban areas, mainly Las Vegas. This appears to be a function of the downturn in the economy, where families are moving to urban areas to find work or to find additional services. This decision unit supports the agency's request to catch up to legislatively approved ratios after 2 bienniums with no new staff to support the continued growth. The staff have continued to serve all eligible individuals. That's just a really big thank you to the staff at the regional centers. No individual has been put on a waiting list. They've just taken on a larger caseload. Our first budget account, 3167, is Rural Regional Center, and this M200 supports funding to remove or to have people receive services that they've been waiting for. They get service coordination, but they are waiting for other services such as supported living or jobs and day training. Budget account 3279, Desert Regional Center, is asking for an additional 41 positions. This would include 20 developmental service specialists, which perform the case management function and service coordination, 3 developmental services 4, which are supervisors, 1 mental health counselor, which would be a behavior specialist that would be assisting treatment teams in developing appropriate programs for individuals with significant complex needs, 2 nursing positions, and then 15 additional support positions that would help build the infrastructure to support the complete array of services that are offered at the regional center. Sierra Regional Center then is also requesting 3.5 positions. And that, it would be the end of the M200, if there are any questions.
And I guess the integration part of this is going to be part of the questions when it comes to caseload growth. Because as we talk about these new positions with developmental services coming into aging and disability, where will these positions actually be located, and how are they going to be managed in that? And we probably should go back and, after we get done with this portion, we'll go back and we'll talk about that, because I'm sure that's going to come up over and over again as we move through with different positions and how it's all going to be transitioned into the same agency. So if we could address some of that along with this caseload, I think that'll answer those questions.
Jane Gruner for the record. The positions in these budgets will stay within those budgets. They're not positions that are integrated into the new division, other than that they would all become part of the division pieces. They would not be moved to Aging and Disability Services.
For the record, Janet Murphy. As Jane indicated, majority of these positions will be staying with developmental services. The ones at Desert Regional Center would be staying there. There's just a couple of the support staff. There's actually 2 IT positions, which would be integrated in, because we're centralizing IT services. And so they would be, they're actually on the organizational charts that we presented early on that would become part of our centralized IT. And then there's one HR position. Again, we're centralizing HR, and so that position will reside in Las Vegas. These positions will reside in Las Vegas, but we're centralizing some of our support services. So those are the only positions impacted. All the remaining services, such as the fiscal, will stay at Desert Regional Center.
Okay, and the 41 new employees over the biennium at the Desert Regional Center, what is the impact of partially filling that versus the full 41 positions? What would impact be if, let's say, there were only 20 positions out of the 41 or 21 out of the 41? What would the impact be?
Jane Gruner for the record. The staff have been functioning way over the capacity of what they have been brought on to do. So there would be an impact. I would say that we would we would hope that we could prioritize which positions would be, that we would be able to have. For sure, our number one position is the developmental service specialist. They do the service coordination and actually do the direct service with the individuals that are coming for service. That said, it's essential that they have the support that they need to do their jobs.
And we have a breakdown of the different recommended positions, some coming in October of 2013 and some November. Can we get folks hired? I mean, we've heard this in other committees. Will we be able to find folks at a psychiatric nurse or some of these other positions that may be difficult to recruit? Will we actually be able to fill these positions?
I'm very confident, Jane Gruner for the record, I'm very confident that we will be able to hire for these positions. Developmental services has been a wonderful place to work for the most part and has a low turnover rate, so I'm confident that we would be able to hire the positions.
Committee, other questions on the caseload? Senator Smith.
Thank you, Madam Chair. I have a couple of questions. So these, in these 41 positions, there are some positions that we normally don't have, I don't think, in the caseload management. So could you address that? Some nursing positions, for example, and administrative positions.
Jane Gruner for the record. Our nursing positions are actually part of our case, have been part of our caseload growth in the past. And it's approximately, I think it's 220 individuals to one. The administrative staff have not always been in this. I think, again, this is a catch-up package from not having additional positions put in. The administrative staff would be supporting the service coordination piece of this, of Desert Regional Center.
Okay. And if I may follow up, just generally on caseload, it seems that some work still needs to be done with our staff on caseload and the growth in the different centers. If you, if you want to comment on that today, that's fine, but I think we do need to have you work with our staff to resolve any differences on caseload.
Jane Gruner, absolutely. We
Okay.
will be available.
Okay, thank you. I mean, if I may follow up and just use an example in the Sierra Regional Center regarding your increase in this budget is 706 clients, but you're currently at 597. There's a pretty big difference there. So that's the kind of example that I want to make sure that we get to the, how you're determining the caseload growth.
Jane Gruner for the record. I'm not sure which page are you looking at?
I'm sorry, I'm on the caseload funding in Sierra Regional. I kind of jumped forward from these positions because I just wanted to get to this before we close to make sure that you keep working with our staff on caseload.
If you would turn to page 36.
Residential support.
That actually gives you the caseload. In the regional centers, every individual, every consumer that we work with has a service coordinator. So it's relatively easy then to figure out what our cases are. And if you turn to page 36, it actually gives you the numbers of individuals that we work with in each region.
Okay.
And at Sierra Regional Center, it's 1,216 individuals. Rural Regional Center, 645, and Desert Regional Center, 3,776 individuals. Now,
And again, I apologize because I had jumped ahead, but like I said, I wanted to get this on the record, I guess, so that we can get our staff working with you on the caseload funding on the residential support numbers as well. Okay, thank you. Thanks, Madam Chair.
You're welcome. Any other questions at the moment? I think what I'd like to do is go ahead and I apologize, we should have started with the integration issue to get that out of the way. There are some questions on that, so if we could go ahead and address that, and then we'll move on to any other issues that we have time with. As far as the agencies, developmental services being combined with aging services, I'm just curious about how common that is, and discuss some of the other reasons why we wanted to do this in other areas, but to give the particular reasons why we want to do it here, and do other states do this? Is this?
Jane Gruner for the record. Across the nation, in the last 5 years, there's been many states that have consolidated aging and developmental services together. A few at the top of my mind would be Kansas City, Kansas, and Oregon and Washington have done some collaborations between those two agencies. And I can get you a list of additional states that have done that. Louisiana contacted me last week. They're in the process of doing a similar integration, including early intervention. So other states have put some additional agencies into this kind of a group, like vocational rehabilitation. Again, it seems that, at least in the last 5 years, states have re-looked at how they allocate funding and where they find the efficiencies. And by putting similar service systems, or that do similar services together, that they tend to find those efficiencies. If you're a senior and you're looking for a person to assist you in your home, it would be a similar provider type that developmental services would have.
And I'm just looking at the discussion we had on continuum of care, how many folks actually transition from like an EIS to developmental services. Have we looked at the number of folks that we will be serving, and how significant is the number to warrant this?
Jane Gruner, for the record. In the current system, the transition is not as great as I would have hoped it would be. I would say that it's a relatively high number of consumers that would be eligible for those programs. Right now, some families transition right into the schools, and they're getting their services through the schools, so they don't necessarily access developmental services until later in the life cycle of the family. I would say currently it's probably 25% of the individuals would transition immediately.
And are there any barriers currently to EIS and developmental services sharing information? I had always just thought in the back of my mind that it would be more along the lines of a referral system from one entity to the other. Are there barriers to that happening, and what will the integration do to break down those barriers?
Jane Gruner, for the record. Currently, the biggest barrier is whether the testing has been completed for the individual to qualify for developmental services. And that piece we're already working on to make sure that early intervention understands what are the necessary protocol for an individual to have completed so that they are able to go right into developmental services. And we're also working on the transition criteria and how that would look. Part of that criteria would be that during the last 6 months of an individual's program at early intervention, they would be working on that piece of transition. So if the individual qualifies for developmental services, they'd already be engaged with the system.
Okay. Yes, Mr. Sprinkle.
Thank you, Madam Chair. Going back to your previous comment, you had said about 25% you estimated, and that was maybe a low number for you, that you had hoped it would be more. Could you maybe elaborate a little bit on why you think that number is so low? And then conversely, by integrating the services, do you foresee it getting higher?
Jane Gruner, for the record. When I say it's low, I think what I actually mean is that I think there's a life cycle for a family as well as an agency. And if you've been involved with early intervention for 3 years, for many families, they're ready to kind of have a normal life and not have to be going to appointments all the time. I think that smooth transition, though, would allow for a lot more preventative care being done. And part of it is, I'm not sure that they always understand that there's a service out there that could support them, and that it isn't the same as early intervention, meaning that you do not have as many appointments in developmental services as you would in the early intervention side of it. But that the smooth transition would be that they would understand what services are available, that they could access the services when they're needed, and that they wouldn't have to complete an application again and testing again, that the transition could be more smooth, that the interchange of information is done outside of the family, that they just sign off on the line that says that they're interested in that service, and that then they would get the information.
So I understand that. I'm just, you had said that you think one of the reasons why is that maybe families wanted to get more to a normal lifestyle, at least for a while. But then you're also saying that by integrating them, it's going to be a smooth transition. So they're still going to want to stay utilizing the services once it's all within one department?
Jane Gruner, for the record. Currently, I would say that that they may not understand that there's services that they hadn't thought about receiving, such as respite. The developmental service side has a intermediate or a little program for families and for young children where there's a set allocation given to the family and they can purchase evidence-based services for their child. It's not as robust as some of the programs that are provided at early intervention, but it would continue that continuity of their service supports to keep the skills up that they have developed already. So again, I think it is just aligning those programs so that the policies match and that it's easy to access. And I think more people will access it.
With that, are there any other questions at the moment? Being none, I apologize. We are not going to make it through today. We have a lot of questions and a lot of things we needed to get on the record. So unfortunately, I will have to invite you back again another day. So my apologies to you and all of your staff that'll have to take time away from the jobs we really want you to do to come back and talk with us. So we'll pick it up with the residential support because we do need to go ahead when we return, because we do need to go ahead and do some public comment this morning, and then the Senate does need to get to chambers within the next 10 minutes or so. So thank you very much for your time, and we'll see you again soon. And with that, I'd like to go ahead and open it up for any public comment that would like to be made. I know we had a couple of people sign in. Mr. Guthrie? Just take the seats at the table. So with that, Mr. Guthrie, if you don't mind, I'll start with the ladies at the end, and we'll work our way across. So please just introduce yourself for the record. Push the button to turn the microphone on.
I can do that.
Okay.
Excuse me. My name is Janice Ayers, and I'm the Executive Director of a 15 rural county program. We've been out there 40 years. I've been coming to these legislative sessions since 1969. I've been working with aging services for 35 years and want to say to you that aging services today has come a long ways, and they're providing wonderful services. And I'm sure you know, because I've worked with some of you in some forums that we've held to let some of you know of what the programs that we're doing. We're a nonprofit organization, and Aging Services serves about 70 or 75 other partners that are nonprofits. And we have somewhere around 1,600 volunteers. And these volunteers provide programs to keep seniors at home. We're concentrating on giving seniors out in the rural areas that little extra help they need to stay at home, whether that's respite care or senior companion. We have a legal service. We provide transportation, and transportation is a real biggie. But there's a tsunami of aging coming towards Nevada, and I think that aging is trying to address this not just with their own staff, but partnering with agencies like my own. And I've seen a tremendous improvement in working with us agencies and making it all work so that you get the most bang from the buck. Our programs are funded by independent living grants and the 3Bs. Unfortunately, the 3Bs, as you know, are under sequestration, and we don't know how that's going to affect us. But I would like to say that we are working closely, I have for 35 years, with aging, and I see these programs really coming together to serve the seniors in the rural areas. And we'd like to be sure that the independent living grants are there. And of course, you can't have much to say about the 3Bs since that's under the feds. But funding these partner agencies is very, very important. And that's why we've been glad to see that the tobacco money has stayed. And if you have any questions, I'd be glad to answer them.
Thank you very much, and thank you for your service. We appreciate all the hard work that you've put in all over the years. Committee, are there any questions? Seeing none, thank you very much for being here today. Please go ahead.
Good morning. For the record, I'm Susan Haas, and I work for the Nevada Rural Counties RSVP program with Janice Ayers. I'm the Director of Marketing and Development. And just to add that working with the Aging and Disabilities Service Unit, we have been working very hard to find ways to maximize services and to get the most bang from the buck. And working with volunteers is just an amazing way of maximizing services and to stretch the dollars that we do have the furthest. Thank you.
Thank you very much. Thank you for being here today. Mr. Guthrie.
Thank you very much, Madam Chair. My name's Ed Guthrie. I'm the Executive Director of Opportunity Village down in Las Vegas, Nevada. Opportunity Village is a community training center. Those of you who are from Southern Nevada probably know about us. For those of you that don't know about us, we provide assessment training and employment services for people with intellectual disabilities. We're essentially where the folks with autism and other intellectual disabilities go when the services aren't provided in early childhood or when they don't work. 47% of the kids become closer to normal or darn near normal. The other 53% of the kids grow up to be adults and need vocational services and other supports. Those individuals are at Opportunity Village, as well as folks with intellectual disabilities and that could be caused by birth defects or they could be caused by accidents after birth. Opportunity Village is the group that serves those people. Last year we provided assessment training and habilitation to 1,695 different individuals down in Southern Nevada. We're very interested in this merger. We think that it'll work well for folks with intellectual disabilities. We think that it's a right move to make, so we don't see any problem with it. I may come back to you 2 years from now and say I was wrong, but at this point in time, I'm saying that I think that it will work, and I think it'll work very well. I'll withhold judgment until I see the completed results, though. We just want to thank you all, because people with intellectual disabilities, people with autism, they have disability. Their disability stops them from communicating their needs, and there's a lot of champions like you, Madam Chair, and others on this committee who champion the needs of folks with disabilities for session after session after session, and we really appreciate that. We also want to thank the governor and Jane Gruner and all the other folks that worked on the budget. We're still in a lousy economy, and so we're all trying to do what we can with what's available, and we know that. We think Jobs and Day Training, when they were talking about how you can leverage money, we think Jobs and Day Training is probably one of the best programs. It's under developmental services. We think it's one of the best programs for leveraging money I've ever seen. I mean, every dollar that comes out of the general fund pretty much gets matched by a state dollar out of Medicaid. But then you give that money to private agencies like Opportunity Village, and they leverage additional money out of contracts that they do. You know, we serve all the meals to all the airmen at Nellis Air Force Base, and we hire people with disabilities to serve those meals. We're one of the larger document destruction firms in Southern Nevada, and we hire people with disabilities to do that. Your money helps us provide that little bit of extra support and supervision that those folks need to be successful when they're out there doing those types of jobs for us. So, as an example, the money that you give us, the dollar worth of general fund and the dollar worth of federal money, actually leverages another $8 worth of private money from Opportunity Village. So you've got, you know, more than half of that is contract revenue, but another good 25 to 30% of our budget is fundraising revenue from events like the Magical Forest and things like that. So it's actually a really great way to do this. You know, our biggest issue right now, if I had to give you two issues, one of the issues the governor is addressing, and we think you can help him with that, and that's that there's a waiting list for services for these types of services as well. There's a waiting list for when the children are transitioning out of school and into adult services, there's a waiting list there. I'm not positive, but I think that DRC has a waiting list of around 300 individuals for jobs and day training services, just as an example. That doesn't count the kids in the school district who are between the ages of 19 and 21 who are going to be eligible for these services. And the last time we looked, there were over 400 individuals that were between the ages of 19 and 21 that are going to transition out. You know, part of the reason we have these waiting lists, part of the reasons we have these problems is because for the last two sessions, there's been no growth in the caseload growth for jobs and day training services, that we've tried to cobble money together from wherever we could in the developmental services budget to try to fund those services. But these are the services that allow families to keep their folks at home. You know, if you've got a child in the Clark County School District who has a severe intellectual disability, and they're going to turn 22 on their 22nd birthday, the bus does not show up. You know, they will be in your home unless you have some other alternative. The funds that you put for jobs and day trainings allow those caregivers to also stay providers for their own families. You know, for the past 16 years while their child is in school, both mom and dad, in this economy, both mom and dad have to go out and find a job so that they can keep the food on the table, so they can keep the roof over their head, etc. On their 22nd birthday, there better have been some alternative arrangements made, or one of those two caregivers has to start staying home. Because many, if not most of these folks need care 24 hours a day. So I guess that's where the biggest point I'd like to make. I guess the second point, if I were going to make one, is that in most of the programs that are served by Aging and Disability Services Division, there haven't been rate increases since the FY 2006 budget. I know there haven't been in developmental services. And it gets more and more difficult over time to hire staff, as you were saying, to retain staff, as you were saying, when you don't have any money to be able to pay the staff. And so it does make things more difficult for us. I don't see that being able to be addressed in this session, and that's unfortunate. But when you're going back to address some of those problems in other areas, I hope that you'll address them in these programs as well. Thank you.
Thank you very much, Mr. Guthrie. Any questions? Seeing none, thank you all very much. Is there anyone else that wishes to make public comment this morning? Please just introduce yourself for the record and proceed.
Good morning. Thank you, Madam Chair. For the record, Connie McMullen. I chair a subcommittee under the Commission on Aging, which has been doing strategic planning for seniors for 10 years. Our strategic plan, as you know, is coming to a close this 2013. will complete its 10 years. As you know, we're facing the hugest tsunami, as was previously said, in the aging and the baby boomer population. I have been asking to update our strategic plan. We did a real good job on completing a lot of the areas in the previous one. I would like to see us updated and move forward. It has been proposed in this presentation today. I, as has been expressed by you, Madam Chair, have concerns as well. I would like to see this done in a thoughtful, mindful way with everybody involved, all the populations, and I think it can be done before this session. So having said that, I too am also concerned about the community-based services. The caseloads have been increased and are slated to go up if approved. We're still short from the 2007 cuts, at least 20 slots. And the CHIP and the residential elderly waiver, I forget the acronym for it. We merged them together, and now I just call it the super waiver. So, but we're still short, and the population is growing. So I'm going to cut it quick, and I know it's been a long day, but thank you for giving me the time.
Thank you very much for sharing with us. I appreciate that. Mr. Uriarty?
Keith Uriarty, Chief of Staff, AFSCME Local 4041. I'll be very brief. First of all, I want to thank you for all of the questions that you had this morning and also those questions of last week. But the answers to those questions are troublesome, and I just want to make one point, and that has to do with the actions that were taken by the Administration of Health and Human Services this Monday, despite a Part C audit that was done in January regarding a community provider. And you heard an answer last week that all of the concerns of that Part C audit had been complied with. I challenged that. And Monday, NEIS staff were directed to once again send children to that community provider without verification that all of those issues raised in that Part C audit had been complied, had been dealt with. This program, as you heard in the testimony of those children or the parents, I mean, this program should be about one thing and one thing only, and that's the children. And this program right now is not about that. Thank you.
Thank you very much. Any questions from the committee? Seeing none? Any other public comment to come before the committee today? Southern Nevada's room is totally empty. So anyone else here in Northern Nevada? Seeing none? Again, my apologies for not completing our mission today, but we will resume on another day. We'll let you know as soon as we can reschedule. Thank you all very much, and we are adjourned. Tomorrow is Subcommittee on Public Safety, Natural Resources, and Transportation, and they will be in room 2134. So have a good meeting tomorrow, Subcommittee.